So session 5.1 is hybrid aorta surgery. So the first talk will be by Dr. Manish Bansal from Gurugram on detailed assessment of aortic valve for AVR AV repair.
Hello.
Hello.
Yeah, good morning. Should I begin? Because I can't see you all.
Yeah, sir, you can begin.
Okay, okay. Let me share my screen first. I hope you are able to see my screen.
Not yet, sir.
Not yet.
No, sir.
Why should it be like that?
Yes, sir. Now you are visible.
Oh, sorry. Just give me a minute. Again, I'll share it.
Fine,
I
sir.
hope it is visible now.
Yeah, sir. It's visible.
Okay. So good morning, everyone. And first of all, I thank the organizing committee for giving me the opportunity to participate in this meeting. I am going to talk about detailed assessment of aortic valve for aortic valve replacement or aortic valve repair. So in a patient who's being considered for aortic valve surgery, the most important information that we need to gather about aortic valve includes first, nature and severity of the valve lesion, etiology of the valve lesion, anatomy of the aortic valve, valve leaflets, surrounding structures like size of aortic annulus, aorta, and then LVEF and other associated lesions. However, in most of the patients who are undergoing aortic valve replacement, what we actually need to know is whether it is AS or AR, whether it is bicuspid valve or tricuspid, and what the sizes are of aortic annulus and ascending aorta. This much information is sufficient for most of the patients. If, however, if the patient is undergoing aortic valve repair, then we need a more elaborate assessment of the aortic valve apparatus. So first, severity of aortic regurgitation and aortic stenosis. So for both these lesions, various guidelines have been published. The American Society of Echocardiography has provided detailed recommendations about how to assess and classify severity of aortic regurgitation. They have proposed some structural parameters, some qualitative parameters, semi-quantitative parameters, and quantitative parameters. This slide shows the commonly used parameters for assessing AR severity, like jet width and vena contracta. We can look at AR pressure half time, flow reversal in descending thoracic aorta. We can calculate regurgitant volume and fraction by PISA method or by calculating stroke volume at RVOT and LVOT. Now, in many patients, these various parameters may not be concordant with each other. So in those cases, we need to take the whole picture in consideration. We look at LV size, we look at the aortic valve morphology, and then decide whether this AR is significant or not. Now, in case of aortic stenosis, severity is defined when aortic valve area is less than 1 centimeter square and mean gradient is more than 40 millimeters of mercury. However, now we have come to understand that in nearly 1/3 of all patients who have valve area less than 1 centimeter square, the gradient is not more than 40. It is on the lower side. So this is known as low gradient severe aortic stenosis. When we encounter such a situation, first thing that we need to do is to ensure that all our measurements are accurate. Then we look at stroke volume. If the LV stroke volume is normal, then it is more likely to be non-severe AS, and these patients have relatively benign prognosis, may be treated conservatively. On the other hand, if stroke volume is reduced, this is known as low flow, low gradient severe AS, and these patients have actually worse prognosis as compared to the patients who present with high gradient severe AS. So recognition of this category is very important. Now, this situation may arise in two distinct scenarios when EF is less than 40%. This is called classical low flow, low gradient severe AS, or when EF is more than 40%. If LVEF is less than 40%, we may use dobutamine echo to see how the valve responds to dobutamine challenge. If there is significant gradient on infusion of dobutamine and valve area remains same, then this is severe AS. If gradient increases, but valve area also increases to more than 1 centimeter square, then it is likely to be pseudo-severe AS, which means that the valve is not severely stenosed, but it is not opening that well because LV force required to open the valve is not there. So this is just one example here. This was a 76 years old gentleman with coronary disease and left frontal branch block. As we can see, EF is 30 to 35%, and his valve area was 0.88 centimeter square, mean gradient 21. He was given dobutamine. There was significant increase in LV contractility. Gradient increased to 34, still not in the severe range, but valve area also increased to 1.14, which means that this was a case of pseudo-severe AS or moderate aortic stenosis, not true severe aortic stenosis. Now, if we find low flow, low gradient AS in the presence of normal LVEF or preserved LVEF, we call it paradoxical LFLG AS. And in such situation, we need to figure out the reason why the gradient is low. This may be small LV cavity. It may be because of uncontrolled hypertension or subclinical LV systolic dysfunction, all of which need to be taken into consideration. And if there's still a dilemma, then we can look at aortic valve the extent of aortic valve calcification by doing CT calcium score. If value is more than 1200 for women and more than 2000 for men, it strongly suggests that the aortic stenosis is severe. Then the next thing that we need to look at is the etiology of the valve region. In case of aortic stenosis, there are three main causes of valvular AS. It could be rheumatic, degenerative, or bicuspid. When the valve is heavily calcified and degenerated and thickened, it becomes very difficult to make out whether it is bicuspid aortic valve or not. But this distinction is quite important because if it is a bicuspid aortic valve, we need to worry about aorta also. So when there is a dilemma, TE may help. And if, apart from TE, overall clinical profile, age of the patient, and whether other valves are involved or not, all that will help in deciding whether it is bicuspid or not. In patients with AR, the etiology can be much varied compared to aortic stenosis. It may be rheumatic valve, degenerative, aortic dissection causing AR. There may be infective endocarditis resulting in para-aortic abscess, disruption of the valve apparatus in AR. This may be a bicuspid aortic valve, rarely quadricuspid aortic valve, annulo-aortic ectasia causing marked dilatation of the annulus, non-cooperation of the leaflets, and here there are many other possibilities. It could be traumatic leaflet disruption, could be aortoarthritis, and so on. So identification of etiology is important here also, because that will decide how we want to treat AR in terms of surgery. Also, what other things need to be taken care of. Like if it is infective endocarditis, then obviously antibiotics for a prolonged duration will be needed. The next important thing is to do key measurements related to aortic valve, and the measurements that are required include measurement of aortic annulus, sinuses at the Valsalva level, sinus of Valsalva level, sinotubular junction, and ascending aorta. Echo is the main modality that we use, but we need to remember that aortic annulus is underestimated by echo, whereas sinuses are overestimated by echo as compared to CT or true dimension. So whenever there is a concern, we can use CT, especially for aorta, because accurate measurement of aortic size is important in patients who've got bicuspid aortic valve, especially when they are in the borderline range like 45 to 55, because then we'll have to take a decision whether the patient needs only aortic valve replacement or also needs aortic root replacement. Now in India, apart from aortic dilatation, in fact, more than aortic root dilatation, a bigger challenge is small aortic root. For example, in this patient, the aortic annulus was hardly 16-17 millimeter. So whenever we come across such a situation, it creates a major challenge for surgery, because then the surgeon has to decide what root enlargement procedure he or she has to undertake, whether it should be a porcine root or some other procedure, because with this small annulus, aortic valve, simple, straightforward aortic valve replacement is not going to be feasible. Sometimes there is extensive calcification of the aorta, known as porcelain aorta. This also needs to be recognized, because in these cases, surgical AVR may not be possible and patient may have to be considered for transcatheter aortic valve replacement. Now, whatever we discussed so far, actually this is all that is needed in most of the patients who are undergoing aortic valve surgery. But as I said, if aortic valve repair is contemplated, then we need a more detailed analysis. We need to carefully analyze all the components of the aortic valve replacement of apparatus, like cuspal height, cusp orientation, whether there is any prolapse or not, and so on. So repair is mostly done for aortic regurgitation, and in these cases, to facilitate repair and to have a common language between the echocardiographer and the surgeon and the other caregivers, a functional classification has been proposed to describe the mechanism of AR. According to this classification, there may be type 1 AR, which is because of dilatation of annulus or leaflet perforation, but leaflet motion is normal. Type 2 is when there is cusp prolapse, and type 3 is when there is restriction of the leaflet movement. So describing mechanism is going to be important for assessing the feasibility of valve repair and what technique has to be used for aortic valve repair. In some patients, there may be multiple mechanisms. Like here, this patient has bicuspid aortic valve, but at the same time, there is a cyst and perforation of one of the leaflets, because of which there were two distinct jets. One was through the commissure and other one was through the perforation. So this also needs to be looked at very carefully. If the patient has bicuspid aortic valve, then merely mentioning bicuspid is not going to be sufficient. If repair is contemplated, describing the orientation of the cusp and the raphe may also have a relevance. And based on the number of raphe that are present, bicuspid aortic valve may be type 0, 1 or 2. Type 1 is the commonest, and within type 1, fusion of left and right cusp, like in this example, is the commonest variety. So in such a scenario, if the two commissures are diametrically opposite to each other, resulting in two almost equal cusps, that leads to better chances after repair, as was shown in this study published in Circulation, that if we have angle between the two commissures more than 160 degree, the chances of long-term durability of repair are higher. In case of cusp prolapse, we need to describe which cusp is prolapsing, what is the extent of cusp, what is the effective height, and what is the jet direction. Also, whenever repair is contemplated, we need to describe the condition of the leaflets, whether there is any calcification, whether there is any thickening, commissural thickening, what the extent is of all these abnormalities, and there are different classifications also for the same. This study, which was published in 2005, 15 years back, showed that in patients who are undergoing repair for regurgitant bicuspid aortic valve, eccentric jet direction of AR and absence of cusp thickening, commissural thickening, and cusp calcification were the four independent predictors of long-term durability of successful valve repair. So these all parameters become important if we are planning valve repair. So to summarize, accurate assessment of lesion severity, etiology, and aortic annulus root dimensions are essential in every patient undergoing aortic valve surgery. A more comprehensive assessment is needed if aortic valve repair is contemplated. Thank you so much.
Thank you, sir. Thank you, sir, for the informative talk. We will take the questions now.
Manish, thank you for your very comprehensive talk.
I'm not able to hear you. Yeah.
I said thank you for your comprehensive talk.
Most welcome.
I was wondering if, as we have indexed aortic valve orifice area index, the overall diameter of the annulus or of the ascending aorta, as we say, a cutoff for replacement should be around 5 centimeters, 50 millimeters or so. when you actually compare it to the height, and especially in the Indian scenario, we tend to lower that if we use the index. Do you have any comments about that?
Yeah, you're right. Actually, the ASC guideline also recommends uh, uh, looking at indexed dimension of aortic root for deciding whether it is dilated or not. You absolutely correct. But in our practice, I've seen that we have not been we are going by the absolute value, which is actually not correct. So very well made point, but we've not been doing that.
Just as a caution again, I think it's important to write down the height of the patient. Sometimes it's not necessarily the body surface area, but I think if we go by the height and the ideal weight, use that as the body surface area and then use that for the index, that becomes a little more accurate.
Absolutely correct.
Thank you.
Any questions from the audience? Thank you, sir. Thank you, Dr. Manish Bansal.
Yeah, thank you so much. Thank you.
So we will begin with the second talk by Dr. Shiv Chaudhary on management of aortic arch in surgery for type A dissection. Where is the fear and what is the justification?
Most of the present time. I'm thankful that I have been entrusted with the responsibility to talk about this. Before I proceed, I must quote Dr. Dhaval. He says that most patients with acute type A aortic dissections are operated on by surgeons with limited experience in aortic surgery. This is true for most of the world. Most of the surgeons operate on one or two cases of acute type A dissection in a year, and they have limited experience. Unlike specialized center, high volume aortic centers in the world, these surgeons usually work alone with limited resources. These surgeons do not have access to hybrid radiology supported suites, sophisticated gadgets, and specialized graft and endovascular adjunct. Thus, considering these limitations of the average cardiac surgeon, I will focus on a strategy which is best suited for the Indian scenario. Before proceeding further, we should be clear about the aim of the surgery. Acute type A dissection is a surgical emergency, and the ultimate aim is to save life. It is done in a hostile environment during odd hours with limited resources and expertise. This goal can be achieved with very simple procedure. Being overambitious may prove counterproductive. It is better to have a live patient. Before proceeding further, we should be clear about the aim of specialized center after some time rather than having a dead patient. Ultimate aim is to save life. We must remember that in inexperienced hand, early morbidity and mortality are linked to the operative complexity. More complex procedure, higher is the morbidity and mortality. Very often there remains a confusion about the choice of procedure for arch in setting of acute type A dissection. I have converted this complex decision making in 3 easy components. First component, without considering any other factor, even if there is no tear, prophylactic resection of the undersurface of arch is mandatory. Thus, hemi-arch replacement is the basic minimum. In step 2, if there is tear in the arch or if it's
Actually, it was a recorded video, so it ended. We can begin with the next talk by Dr. Samir Dani on Are We Still Ignoring Type B Dissections? Dr. Samir Dani.
I'm sorry for a small interruption. I think just Dr. Siv Chaudhary's video is still loading. Very interesting talk. So once it just get loaded, just we'll run it again because it's very important talk. Meanwhile, Samir bhai, you are ready with your talk. Yeah. So Dr. Samir Dani is here and just he's going to speak on are we still ignoring type B dissection? Followed by Dr. Girish Varavarkar, he is here, and Dr. Rochan Pant. Meanwhile, just update us when Dr. Shiv Chaudhary's video is ready, and we'll run in between. Okay, thank you.
So very good morning to all of you. We are going to, the topic of discussion, are we still ignoring type B aortic dissection? In few minutes, I'll try to tell you that no, we are not. The cardiovascular conditions, the incidence has been increasing significantly over the past few decades. And not unlike coronary artery disease, valvular heart disease is also on rise, and so is the diseases affecting aorta. Unlike congenital heart disease, which is fairly static, as you can see. The incidence of acute aortic dissection is also on rise, and not only this decade, you can take any country, the incidence of aortic dissection, even thoracic aortic aneurysm and dissection, everything is on rise, and operations are also on the rise. Initial management of suspected acute aortic dissection is outlined somewhat over here. Once the dissection is confirmed, if it is type B, it used to be continue medical management. But then it has evolved from 2000 onwards, 2002 onwards, or I would say specifically 1999 onwards, because 1999 was the first case report in NEJM when type B aortic dissection was repaired using TAVR. Until then, the surgical treatment used to be really morbid and had high mortality, in fact, higher mortality compared to medical treatment. So this particular case, which was reported in 1999, showed that there was good amount of aortic remodeling after the TAVR. The true lumen enlarged and false lumen completely thrombosed. But we quickly realized that the type B aortic dissection is not a homogeneous entity. Type B aortic dissection can be low risk, uncomplicated, without any hemodynamic compromise, without any ongoing chest pain, without any evidence of malperfusion of the organs. And type B can be with all of that, hypotension or malperfusion or ongoing chest pain or quickly enlarging false lumen. And these high-risk patients did not do well. In even first 30 days, the curves start separating and they have very high mortality. So survival with acute type B aortic dissection on drug had a curve like this, where it was significantly going downhill over a time period. And this curve was going downhill not only in first 30 days, but it goes down across all 5 years, 7 years of follow-up. And it depends very much on the medical management also. So chronic type B dissection on drugs can look like this, and sometimes it is very ghastly and it becomes very difficult to treat once it becomes chronic and complicated. The INSTEAD trial tried to or attempted to answer this question, what to do with type B aortic dissection, which is uncomplicated. We had realized that complicated type B aortic dissection is best treated by endovascular repair, and if it cannot be repaired with endovascular procedure, then surgery came into picture. But medically, you can't manage these cases. Instead, tried to answer that question, that what happens to uncomplicated type B aortic dissection if we subject them to TEVAR rather than medical management. And at 1 year, crossover rate was 14%, 2 years crossover rate was 20%. The survival curve did separate, but there was no significant difference between TEVAR and the medical management. So the take-home messages from INSTEAD were that probably both are equal, though there were signals that aortic remodeling was better when the TEVAR was performed. Freedom from progressive aortic disease, there was a signal that TEVAR was doing better. But then INSTEAD AXEL came when they performed a 5-year follow-up of INSTEAD patients. And then the curve started separating. Because in INSTEAD AXEL, they could show all these where INSTEAD was a randomized control trial, but the number was small. But still, they could show that over a period of 5 years, there was a long-term advantage of endovascular procedure with true lumen enlarging, aortic remodeling more favorably happening. The quality of life was better. And then the data from IRAD, the registry, ongoing registry, came that the survival curves also probably were separating. ADSORB also was a trial which showed that there were signals that endovascular procedures are better. Simultaneously, amongst the devices, also there was evolution or revolution. There were so many devices available. And finally, by 2014, the guidelines looked something like this, that in uncomplicated type B aortic dissection, medical therapy should always be recommended, class 1 indication with level C of evidence, but TEVAR should be considered recommendation class 2A with level of evidence B. In complicated type B aortic dissection, TEVAR is always recommended, which is a class 1 recommendation. And in complicated type B aortic dissection, where TEVAR is not possible, surgery may be considered, which was a class 2B recommendation. So by 2014, we knew this. And this knowledge percolated everywhere amongst all the guidelines by 2017. And slowly we have started talking about more evolving indications for type B, that not only cardiogenic shock, not only perforation, but ongoing chest pain, intramural hematoma, certain CT features came into play, which tell us that it is better to do endovascular repair, TEVAR, rather than continue these patients on medical management. We also came to know that it is better to offer TEVAR in subacute phase rather than chronic phase, subacute phase rather than acute phase also. We'll come to that. So the management schema changed by 2015, that if you have type B dissection, but you have complications like aortic rupture and or organ ischemia, continuing pain, hypertension despite full medical therapy, hypotension, early false lumen expansion in first 2 weeks, large single entry tear, then these were the indications where you go in endovascularly and perform a TEVAR. If all these things are not there, then that is real uncomplicated type B, and then you continue with medical treatment. But this is not enough. Now we have more data, and that is those type B who are kept on medical management, who were uncomplicated to begin with. When they become chronic, they show aortic inflammation, sometimes, not all, but many of them show aortic inflammation, which is picked up on PET-CT and MRI. And these are the ones who do not do better. These are the ones who start going downhill after 2 years and 3 years. So the Stanford aortic dissection risk calculator started calculating all these. Connective tissue disease, yes or no? Connective tissue disease means there is no endovascular repair. You straight away go for surgery. Maximum aortic diameter in the dissected aorta, circumference of the false lumen, identifiable aortic intercostal arteries in the area of the dissected aorta. What is the false lumen outflow? You calculate from left subclavian artery, celiac trunk, superior mesenteric artery, left renal and right renal, inferior mesenteric, all the visceral arteries, whether they are coming from true lumen or false lumen. And based on that, you calculate or give a score to all these points. And those patients who were high risk as per this score, when they were followed up over a period of 6 years, 5 years, they showed significant difference in survival. Even other things, that when those patients were given TEVAR, an uncomplicated type B, the remodeling was better when it was done in subacute phase, or when they were complicated, it was done in acute phase. So basically, we used to be taught like this, that there is a type A and there is type B. It is complicated and uncomplicated, and uncomplicated has mortality rate of 10% if managed medically, and uncomplicated has a mortality rate of 58% if managed medically. So that's why complicated should be treated, uncomplicated should not be treated. But that has changed, because type B dissection does not necessarily remain uncomplicated. That also evolves or devolves. So the dissection is an ever-changing disease. Essentially, there is no one who is not at risk. Temporal survival by acuity, you can see the separate curves as the years go by. And to say the least, there is big impact on the lifestyle also in those uncomplicated aortic dissection who are managed medically. So the future management schema, or 2021 schema, if you will, looks like this, that those uncomplicated type B dissection on the right bottom corner, even when they are deemed low risk, there are no high risk parameters. You do a pre-discharge CT at 7 to 10 days. You look for high risk parameters like false lumen expansion in those 10 days. Repeat the CT at 3 months. If there are no high risk parameters, reassess and do a CT follow-up protocol. And the moment you feel that this uncomplicated low risk type B aortic dissection is changing into high risk, you do the TEVAR. So to conclude, as the Pope said, God created the aorta with only one canal, and that's how it should stay because he was treated for this. Thank you.
Thank you, Dr. Samir, for the excellent deliberation. So the conclusion is that type B, despite being uncomplicated, should be treated endovascularly as and when possible.
Whenever you feel that it is high risk.
Thank you. Any questions, please?
Thank you, Samir. What I'm just saying is some more of a comment rather than a question. I think unlike type A, where there is an underlying disease for that dissection to happen, type B is most often a hypertensive disease. And therefore, I think enough emphasis is not being given to the root cause. And therefore, aggressive antihypertensive management has to be emphasized at every single deliberation of ours regarding type B aortic dissection. As you rightly say, the numbers have increased. That is also because the age has increased, the overall age, and the detection has increased, as well as hypertensives has increased. And I think prevention ultimately is the best, especially in type B, and an aggressive antihypertensive treatment ought to be deliberated on.
Thank you, sir. So we will begin with the next talk by Dr. Girish on management of complex aortic disease hybrid approach.
Good morning, everybody. Thank you, Dr. Dhaval, for inviting me for this talk. Aorta has been very close to my heart, so I will tell you what are the things that are evolving in the management of complex aortic arch disease. In perspective, majority of the demands of EVAR and TVAR have been met with the chimney, fenestration, branch grafts, CMDs, resulting in the push of the limits that we can treat difficult pathologies with good outcomes. The arch poses a challenge due to the diverse anatomy of the anatomical variations for TVAR, and hence the thrust to address these challenges. So what is the big picture? Innovation, doing something different that matters. Why is it minimally invasive arch surgery important? Are there many cases? Are we doing being innovative just because we can, or does it matter? So when why is minimally invasive arch procedures important? Basically because descending thoracic aortic surgery has transitioned to endovascular treatment as the first line of therapy. So you have different varied anatomies that you can have. It is important that we do this because it's a closed chest procedure. It has, and its implications are less than what you would have in open. Solving the arch branches and angles is critical piece of the puzzle. In current revolution of modular closed chest aortic reconstruction, we have now TAVR, ascending aorta, arch, descending aorta, and thoracoabdominal. Better not to let this train leave the station. So what are the closed chest options for a healthy 70-year-old patient? Single branch endograft off the shelf, multi-branch endografts. They could be custom made or off the shelf. So you have a single branch aortic graft. Off the shelf device is designed for left subclavian artery or innominate artery, modular system, dual wire lumens. You have the Gore FDA study, which has 6 sites. First in man was in January 2014. Then you had the Medtronic Mona LSC FDA study, again, first in man in 2013. Single branch graft combined with extra anatomical carotid bypass for full arch reconstruction. You can see this in June 2016. Enrollment was started by Gore FDA feasibility study. Feasibility trial completing, moving to a pivotal trial now. Then you had the, in 2016, early feasibility study of acute type A dissection. 3 sites in Houston were enrolled. Technology is here and future generations will improve on the shortcomings of the present device. In 2017, in single branch aortic graft, a good solution for a lot of patients. You have a branched graft, and you can treat anatomies like this, you will see in the central picture. So you have also got chimneys, snorkels, again in the closed chest. It's off the shelf, conventional device. Concern with guttering and endoleaks is there. It could cause branch compression, large diameters of the innominate artery, and increased stroke risk because you are dealing with the arch vessels. Data lacking in the interaction between the parallel placed aortic stent graft and the stent to the great vessel, because it's a chimney. Maintains main indication is emergencies when custom devices unavailable, but being used electively in part of the world, and not a good option for our patients today. So then you have the multi-branch grafts. This was by Cook. There was you do a carotid subclavian bypass pre-op, main body deployed transfemorally, head vessels cannulated from above, a narrowed body in the arch. These are the branch grafts that you have, multi-branch grafts. We have coming from Zenith. If you see, the A is the internal, is the main component. B is the internal side branches, and C is the external viewing of the internal branch grafts along the outer curvature of the main body. So this is what the Cook branch graft looks like. There are more than 200 cases worldwide. Largest published series was 38. Reported early stroke rate was about 10 to 15%. So, which is pretty high, and we need to address this problem whenever we are doing a procedure of the arch. Then you have the tagged branch grafts. So basically, these are the different grafts that are available from different companies. Then you have the Medtronic graft, which is called the Mona, Valiant Mona. So these are the 3 components that you have. And then you have the Nexus, which is basically Z-shaped of the main module. It has a fixation, continuous flow path to the brain, through access off the shelf device. So you can do it in kind of emergencies if the graft is available in your city or in your hospital. Then you have fenestration options where you fenestrate the PTFE. And in June 2016, human feasibility studies were done, and compassionate cases, about 8 patients were done. So this is what it actually looks like. You will see the main body with one branch.
And then you have the different other components that you will place thereafter through the main body. So Bolton branch graft look like this, double branch graft, which is placed in the ascending, and then you are cannulating each of them through the innominate and the left carotid. This is the Brayley's branch graft. It's a triple branch graft. And then you have, it has come, it has gone. We don't know. This is the multi-layered stent, what they call MFM. And what is the future is endobental. Now I'll just go through one case, which is an interesting case, which will tell you what the possibilities are and what the problems are. I was, unfortunately, we couldn't hear that talk on the management of type A dissection. So hopefully we'll see it. And this is one of the complications of that. So this is the future basically. And to treat type A dissections, you can have now the endobental, which is coming, which will treat not only that, but it's still under the development stage. Now, this is a 71-year-old male presented the type A dissection in 2014 in outside hospital, treated with an ascending aortic replacement only, came in 2015 with an enlarging aneurysmal false lumen. Total debranching was done followed by TVAR with 2 endografts. Procedure was done by the other interventional radiologist that was there in the hospital, not me, followed by this previous IR followed up with me with that previous IR in 2016. And this was his notes. You can clearly see that here it is written CT angio type 1 endoleak, no expansion in the aortic aneurysm size. To follow up, continue all medical management. When you saw his CT when he came in 2016, this is what the CT looked like. It looked pretty okay. However, and this is the X-ray, but he presented to his local physician in another city in June 2019 with shoulder pain. His GP examined him and asked for an X-ray chest. And this is what the X-ray chest showed. So there is total disruption of the 2 grafts. And this is what the CT looks like. Now there is also extension of the aneurysm now in the thoracoabdominal segment. This is the CT done just before we took the patient up for surgery. I hope you can see the CT a little better from this distance. There's a total disruption of the graft. At some segment, you don't see the graft at the stent graft at all. So, what were the mistakes that the first IR made? First graft not positioned correctly. If you can see a little better, you will see that the graft here is placed much higher than it should be. The first segment should be across the debranching graft, which is much higher. So that was one problem. The first graft was a 40-40-200. And within that, he placed a 38-38-200. Obviously, you cannot place a smaller graft into a bigger graft. You can always put a bigger graft into a smaller graft. And I presume that is the reason why the whole segment separated. So we took the patient up, and when we went, we decided we line the whole thing again, but it refused to track. You're seeing it, it won't go beyond because of the multiple curves. So we had no option. We tried everything, put a second stiff wire, still it would not go. So finally we went transseptal. That I didn't do. I asked the cardiologist to help me out. He gave me a transseptal puncture. I snared the wire from the left ventricle and pulled it out from the femoral vein. I had an access both sides now. And then we went ahead and did the entire graft placement. We placed the last graft below. And then we, just to be on the safe side, we put a covered stent in the SMA so that we don't jail the SMA. Then we ballooned the whole thing. And this is the final angio we got on that day. Looks good, no obvious endo leak. And there is good flow down. This is the just plain still images. So he came back after 1 month as we normally do for follow-up. And if you see, there is a massive endo leak, type 1A as well as type 1B. You'll see here, you can see a type 1A, and lower down you'll see there is a type 1B endo leak. Here, at this point. So we said, no, now we need to do something. So we decided, let us balloon it again and see. It didn't make any difference. We went with a catheter into the endo leak. It was quite obvious. So after ballooning, we said, let's see what it is. But both the leaks persisted. So then we took another graft and extended it below, and also extended the reverse chimney for the SMA. We extended the SMA, sorry, 1 minute. And ballooned everything out. And, oops. Shit. Just excuse me. Okay, so we ballooned everything out, and we still see a slight endo leak, not as much as before. So we decided now this is not good enough. So we managed to go into the endo leak, inflated a balloon in the main, and then we injected glue into that segment. And after we injected glue, you can see that the endo leak, type 1B endo leak, stopped. However, after that, if you see here in this CT, again, there was that type 1A endo leak, and we were in a fix. How do we treat it? So we decided on seeing the CT, we'll take a mini thoracotomy in the 8th or 9th intercostal space. We accessed it with a sheath and tried to go through the thrombus to the leak site. We managed to a point. However, after injecting the Minox or the glue, you can see we are injecting the Minox. It's getting darker around. And then we repeated the CT, and the CT still showed that where the primary leak was, the type 1A leak, was not being reached. That was along the upper surface. Now you can see here, you are seeing the endo leak here. You are not seeing any leak below. So we went, this was the window of opportunity we got. We went under CT guidance percutaneously, put in a Chiba needle here, and shifted the patient into the cath lab, and then put in a sheath and injected glue. Now, this is the microcatheter at the site of the leak, and you can see it's a pretty big leak. And thereafter, I'm nearly through. We injected the glue, and thereafter we did the angio, and you can see now we have sealed the endoleak. This, the top one is the plain and the bottom one is the post contrast. There is no endoleak. He followed up till about 1 month ago. Unfortunately, he developed a pulmonary infection and died about a month ago. So, bottom line is, first attempt is the best attempt. Don't compromise at the first attempt. Plan the procedure well and leave no stone unturned to seal type 1 endoleaks. So this is what the future is for the ascending and the arch. And task today is to define why minimally invasive arch is important. Solving the arch is a critical piece of the puzzle in current revolution of modular closed chest aortic reconstruction. Thank you.
Thank you, sir, for your wonderful talk. I'm not very sure whether we have time for questions. However, Jagdish, you want to ask one question? I think we won't take any.
The longest follow-up I have, because we've started doing this somewhere around 2001. So it's been about 18 years. I will tell you, I must have done more than about 350, 400 TVARs, EVARs. I'm not talking about hybrid, I'm talking about in general. And what we follow them up rigorously. Our follow-up is 1 month, 6 months, 1 year. If there is no problem, then annually for the next 8 to 10 years. And we have a pretty good follow-up. There are some dropouts, of course. But the point is that we have seen that there are endoleaks that develop, which would be, I would think, about 20%. And if you pick them up early, we can treat those endoleaks, as you can see in this patient. There are others where we've seen the endoleaks in the first sitting itself, and we have treated it immediately. But saying that, our results over the last 15 years has improved, our techniques have improved, the devices have improved, and we see pretty good results without major problems with these grafts. Ten-year survival is at least 50%. And this patient again, now, yes, we lost him about, did it in 2019, and we lost him this year. This was about a month ago when his son called me up. They were suspecting that he had endoleak. 1 month before that, we had done a CT which showed clean. And they were saying that he had some chest infection. It didn't look like COVID. They did a RT-PCR, it was negative. But they were suspecting he developed COX. We don't know.
Thank you, sir.
Thank you.
I think in the lack of time, we'll proceed
Sure.
to the next one.
I'll take the laptop. Thank you.
Thank you, sir. So next will be Dr. Roshan Pant with advances in management of thoracic abdominal aortic aneurysm.
Good morning. Thank you so much for having me here. And this is about what is new in the advances in the management of thoracoabdominal aneurysms. As we know, thoracoabdominal aneurysms are a difficult problem, and the Crawford classification, which is pretty old now, classifies this for surgical purposes. When we talk about people like me, we are endovascular, and this classification doesn't really help us much in the management, but that is how they are labeled now. So the main concerns with thoracoabdominal aneurysms are these, that there are visceral branches arising from the aneurysmal segment or the landing zone. They have to be preserved. Whether when we are doing the procedure, the thrombus usually associated with these aneurysms, whether that will embolize and cause damage. There can be spinal cord ischemia if you cut off a large portion of branches from the aorta, and renal dysfunction is always hanging over heads in all these patients. So the approaches are surgical, surgical repair of thoracoabdominal aneurysms. I'm not the person to talk about that. Endovascular approaches, there is the hybrid approach where the branches are preserved by connecting the visceral organs to a zone which is not aneurysmal in the aorta, or a branch preservation by other means, which basically includes flow diversion. Dr. Girish mentioned the MFM. We don't know its status, so I will not talk much about that. It's not been available for quite some time. There are custom devices with holes and branches, which are made by various companies, Cook, Curotech. Almost all the companies which manufacture stent grafts, apart from Medtronic, have a fenestrated branch program, and you can order a custom-made device for your patient. It takes time, a long time, and the other alternative is to custom make it yourself, which is physician-modified stent grafts. Then the newer developments are, which has been a sort of a dream for a long time, are off-the-shelf devices. Because in an emergency, if you don't have the experience of making custom-made devices yourself, there are not too many good options that you have. So device in these cases is customized to each patient when you order it from the company. But the problem is if the patient, it takes time, 6 weeks upwards, maybe right now with post-pandemic, I don't know how much the time delay is. And the cost is high of these devices, but they come made by the people who make the stent grafts. The other option is this. We modify the stent graft ourselves, make the holes, create the branches, whatever we need. This is something I'll talk about briefly. Obviously, with aneurysms like this, intense planning is necessary. And we make the plans on the CT scan. The CT scan where we take the CT scan data and reform it in various ways. Multiplanar reformations, curve planar reformations, straighten out the curved tortuous aorta and make the measurements to create a plan. For example, say an aneurysm like this, which is juxtarenal. As you can see, there is no real good landing zone near the renal artery. We will make a plan something like this, where we've got a right scallop and a left fenestration with a bridging stent graft. And we do something like this. Get in there, you can see the renal artery there and the aneurysm. A partially deployed fenestrated graft with a scallop on the right and a fenestration hole on the left. You can see the markers for the fenestration. Go into the renal artery across that hole in the stent graft, and then put in a guiding sheath and then deploy a bridging stent graft. That's the deployment of the stent graft into the left renal artery. And this is the completion of the deployment. And you end up with something like this when you complete the bifurcated EVAR device placement. Iliac limbs. And there's the follow-up CT of the patient. So similar case, this time we have done bilateral stent graft placement. You can see it on the follow-up CT. So these are juxtarenal aneurysms where only the renal arteries are of concern. But we know that thoracoabdominal aneurysms can be much worse and all visceral branches can be involved. For example, a case like this. Now, this gentleman is reasonably young for something like this, and he continues to have pain abdomen. So I think is something going to happen very soon. So I don't have good options but to start taking up this patient myself. So that's the CT scan. But you can make out in the reformatted images what this aneurysm looks like. And obviously there isn't much of a landing zone below. So you have these, probably all 4 branches need to be preserved. Otherwise you'll not have a distal landing zone adequate to support the stent graft. So in this position, we make a plan like this. In any case where we are doing fenestrations, the plan is extremely detailed. We take a long time over all the measurements. We measure it number of times, make a formal plan like this, where everything is labeled and you know which side is right, which side is low, which side is up, which side is down, and how it will fit into the patient. Then we start the case. Here you can see the initial angio, and these wires which you see on the side, these are 18 wires which are placed just to mark out the origins of various arteries so that we don't have to use too much contrast to try to get into them. We go across the fenestrations that we have created into each branch. You can see here renals, SMA, and the celiac. And then, as I showed earlier, we come into each branch with the guiding sheath and then place these bridging stent grafts into these branches. The reason I'm showing this particular case is because this illustrates the joys and perils of what we do. So fair enough. And then the constraining suture, we break it using a balloon so that now the stent graft can fully expand. And we see at the end, all 4 branches are filling. And we are presumably happy with this. But in the morning, suddenly the patient has hypotension. I'm called at 5 a.m. in the morning after finishing the last evening. And patient has sudden hypotension. So blood is started, puncture sites are all fine. So we say, okay, shift the patient immediately, do a CT angio. We do a CT angio, and we see, you can see here in this image, there's a perinephric hematoma. And that explains why the patient has hypotension. When we finished our case, you remember we showed the renal artery, everything looked okay. But obviously it's not okay. So then we go in and we find this. We place this stent graft to block a pseudoaneurysm. I think I've skipped a slide here. Okay, it doesn't matter. So we had to place this stent graft again because there was a pseudoaneurysm in this area which was causing the bleeding. So now we said, now it's okay. We are done. We saved the patient's life. We are fine. But then we repeat the CT and we find there's an endo leak because the celiac bridging stent graft has now lost its seal with the main body of the stent graft. So this seal zone is a problem in these devices. It's a fragile, narrow area where the bridging stent graft is in contact with the main body. Obviously, we had to go in again, and it's fairly straightforward. We had to extend the bridging stent graft more into the main body. We did that. Everything was fine. We finished. And this is the follow-up CT. As you can see, everything is okay here, right? So why I wanted to show you what can go wrong in this is because it is a complex and difficult procedure, and obviously it is not the perfect answer. So brings us to the complications. On the left, you have complications of open surgical repair. On the right, you have complications of fenestrated branch stent grafts. So fenestrated branch stent grafts obviously have lower mortality morbidity in the perioperative period. These are good. But look at this reintervention rate, which is what Dr. Girish was showing us. With stent grafts, this is an issue. We do not, of course, have the perfect answer yet. Maybe we need to understand more about the biology of what happens in these aortas, because as the aorta, even after the stent grafting, the wall continues to change and evolve. So it's not as if one point solution is going to last forever in all patients. We know that. So they need monitoring afterwards. So now we talk about the off-the-shelf devices, which almost all the companies are getting into, trying to give you a solution to an acute case where you're worried about rupture. This is basically many sizes will hopefully fit most, somewhere around 88% of patients will fit. These devices will fit. Of course, we don't have any of these devices. Only one device is FDA approved, which was the Cook T-branch device. But these are basically devices which just come out. Yotech has got approval in Europe, and I think FDA also. And this uses something called an inner branch. An inner branch is basically there is a longer landing zone for the bridging stent graft inside the stent graft, not outside. Like chimneys are parallel stent graft which lie. The bridging stent graft lies outside the stent graft. Here, you are extending an inner branch inside, so there is a longer seal zone. What I spoke about, the narrow seal zone in a usual fenestration, that is solved by this, right? So this kind of thing is what inner B study is going on. We hope to see the completion, and we'll come to know what the data is. But device is in use with the exemptions in Europe. So this case is from Germany, what you're seeing here. And you can see these are the inner branches. They are inside the main body of the stent graft, unlike what I showed you earlier, where the branch was mainly outside and narrow. So the Cook T branches, this device, according to in UK, where I had speaking to them just recently, and they used a lot of these for some patients. but it fits for about 60 to 70%. The Cook claims it fits 80%. It doesn't. About 60 to 70% of the acute cases they tend to manage with this. Other cases, they have to do the physician modified stent graft procedure. So this is the Cook device T branch, and these are the sizes which it has and which I'll talk about later. Now the Gore device is very promising, which is under development, which is again an inner branch device with pre-wiring so that we are very quick in deployment. You can see the SMA and celiac branches are downwards, the renal branches are upwards, and it finishes off with a bifurcated EVAR device. So it uses this through and through axis reloaded wires, and this is the post-deployment picture. This was, I think, the first case done with this device. Second case was in Mayo Clinic, and they have been proceeding this time. So they are close to finishing their trial. This is a device under development with our northern Chinese neighbors, a company called LifeTech. I don't have too many details about this, but they are saying that they are carrying out a trial. So we'll find out at the end of it how successful they have been. These are the sizes that are published about these devices. You can see the sizes which are available are limited. And this is a problem because in India, the aortic sizes are very different from in the West. And this data is from, I think, the means are from CMC, and the lowest one, infrarenal, it includes some other places also. So you can see our aortas are smaller, and the infrarenal part particularly is much narrower. And I do not know if we put such oversized device in there, what is going to be the long-term result. So this is a problem that I foresee with off-the-shelf devices, at least in India. To summarize, customized devices are available, and if you have time, they are the best bet right now, if you have time and money. Off-the-shelf possibly will be a new era for at least management of acute syndromes with thoracoabdominal aneurysms in that region. Indian sizes is potentially a problem because even right now we know that stent grafts in some of the especially female patients, we do not get stent grafts of the right size. And that's it for me. Thank you for your patient listening. If any questions, I'll be glad to answer. Yeah, so multi-layered stents came in. There was a lot of, so basically the idea of this started with neuro. So in neuro, the flow diverter, which is basically the same thing, is pretty well established now. But the thing is, the neuro arteries are very different. The aorta particularly is an elastic artery of a much larger diameter. The theory of the flow diversion is that the flow diversion stent stops turbulent flow, does not stop laminar flow. Laminar flow is smoothly flowing parallel sheets of fluid, assuming that we are talking about Newtonian fluid. The moment you go below a certain size, it no longer remains like that because viscosity becomes very important then. The issue with the MFM has been, there have been reports of post-MFM deployment ruptures in aneurysms in Europe and other places. In India, the problem is we have hardly any cases to talk about. I don't know how many total cases were done in India before the device was no longer available to us. So I really don't have much to talk about. There are a few cases where there was a lot of improvement, but basically those cases which I have seen, and I have experience of one case with follow-up of about 3 years. After that, I haven't seen that patient again. That patient had multiple saccular aneurysms, not your classical thoracoabdominal. He had multiple saccular aneurysms in his aorta. I don't really know what he had. Obviously, most of the time you can't tell why these things happen. And these are rare things. So he had improvement in some aneurysms. Some aneurysms still continued to be patent at the end of 3 years, but there was no growth in any of the aneurysms, and he was asymptomatic. But he did develop a renal artery stenosis post MFM deployment, presumably because of the MFM, because there was no plaque there. So I'm not too sure whether the claims are all valid, and the data is still, perhaps in dissection, they have a role which is more. But in true aneurysms, I am not very sure that I would recommend it to anybody if you have options. If that answers your question. Thank you.
The next.
Thank you, sir. We will continue with the previous recorded video of Dr. Shiv Chaudhary, management of aortic arch in surgery for type A dissection. Where is the fear and what is the justification?
Good morning. The optimum management of aortic arch during surgery for acute type A dissection is one of the most debated topic of the present time. I am thankful that I have been entrusted with the responsibility to talk about this. Before I proceed, I must quote Dr. Dhaval. He says that most patients with acute type A aortic dissections are operated on by surgeons with limited experience in aortic surgery. This is true for most of the world. Most of the surgeons operate on one or two cases of acute type A dissection in a year, and they have limited experience. Unlike specialized center, high volume aortic centers in the world, these surgeons usually work alone with limited resources. These surgeons do not have access to hybrid radiology supported suites, sophisticated gadgets, and specialized graft and endovascular adjunct. Thus, considering these limitations of the average cardiac surgeon, I will focus on a strategy which is best suited for the Indian scenario. Before proceeding further, we should be clear about the aim of the surgery. Acute type A dissection is a surgical emergency, and the ultimate aim is to save life. It is done in a hostile environment during odd hours with limited resources and expertise. This goal can be achieved with very simple procedure. Being overambitious may prove counterproductive. It is better to have a live patient who can undergo elective reoperation at specialized center after some time rather than having a dead patient. We must remember that in inexperienced hand, early morbidity and mortality are linked to the operative complexity. More complex procedure, higher is the morbidity and mortality. Very often there remains a confusion about the choice of procedure for arch in setting of acute type A dissection. I have converted this complex decision making in 3 easy components. First component, without considering any other factor, even if there is no tear, prophylactic resection of the undersurface of arch is mandatory. Thus, hemi-arch replacement is the basic minimum. In step 2, if there is tear in the arch or if it's dilated, it needs to be eliminated. If the tear is limited to the lesser curvature of the arch, an hemi-arch replacement is sufficient. However, if the tear is present along the greater curvature of the arch, a more extensive arch replacement is required. Third step is the most debated topic nowadays. It is a prophylactic procedure in most of the cases and is carried out to prevent late complications of distal residual resection. It is purely optional depending upon the infrastructure, logistics, and experience. If one decides to opt for this procedure, a covered stent graft is placed in the proximal DTA. This is frozen elephant trunk or FET. In current times, there is no role of conventional elephant trunk in the setting of acute dissection. To decide about to use or not to use FET, we should understand the natural history of the distal residual dissection. There are certain facts which are accepted by most of us. Firstly, if left untreated, distal false lumen may thrombose completely or the false lumen may not dilate further in majority of patients. Thus, the majority of patients with type A dissection may not require any further intervention. If left untreated, distal false lumen may become aneurysmal in high-risk patients. What are the high-risk patients? We will discuss in a short while. At the same time, literature has also shown that frozen elephant trunk increases the chances of false lumen thrombosis and aortic remodeling. Another factor which favors the use of frozen elephant trunk is the presence of distal malperfusion. It is well-established fact that frozen elephant trunk help in resolution of distal malperfusion. But equally important is to remember that pre-operative malperfusion gets resolved in majority of patients after proximal repair. Thus, all patients who have radiological or clinical evidence of malperfusion may not require frozen elephant trunk. The world literature and cumulative global experience has shown that frozen elephant trunk is definitely helpful in selected cases, and these high-risk cases are tear in the proximal DT or isthmus, retrograde type A dissection, evidence of distal malperfusion, and aneurysmal disease of the proximal DT. Though frozen elephant trunk has shown distinct advantages in terms of aortic remodeling and resolution of malperfusion, there are two major concerns. Frozen elephant trunk increases the incidence of paraplegia. Secondly, it requires radiological assistance and a device which may not be available immediately. Thus, it may delay primary repair and increases the early mortality. Thus, if we plan to opt for frozen elephant trunk, important consideration is that should it be an integral part of the primary repair or should it be delayed? That is sequential. If frozen elephant trunk is an integral part of primary repair, there are certain concerns. As mentioned, it may delay the primary repair and can increase mortality. It may cause paraplegia. In post-operative period, on the one hand, we try to control the blood pressure, thinking in terms of bleeding, but the lower blood pressure may increase the chances of paraplegia. Similarly, any hemodynamic compromise will have adverse impact on the incidence of paraplegia. Thirdly, in acute phase, the septum and the tissues are very friable, and any intervention has chances of high chances of rupture. The other option is to delay frozen elephant trunk. In this, a stent graft is deployed as a planned elective procedure, usually after 2 weeks. This eliminates the infrastructure and inventory-related restrictions. As there is no risk of bleeding, blood pressure can be maintained in higher range after the stent graft, and this will have a positive impact on the incidence of paraplegia. At the same time, the tissues are less friable, so there are less chances of rupture or stent-related complications. Considering all these facts, I follow a middle path. That is, endovascular compliant proximal repair in stage 1 and delayed elective stent graft in selected patients after a period of 2 weeks. Now coming to exactly what do I do? We follow an extremely simple algorithm for the extent of arch repair, and the choice of procedure depends on location of intimal tear, diameter of arch and proximal DTA, evidence of distal malperfusion, and presence or absence of connective tissue disorder. Depending upon the morphology, there are 3 options for primary repair. That is hemi-arch only, hemi-arch with debranching, and arch replacement with debranching. If there is no intimal tear or there is a tear along the lesser curvature without any dilatation of the arch or proximal DTA, a standard hemi-arch replacement is performed in an open fashion. This is usually sufficient in most of the patients. However, if there is any of these conditions, that is tear in the proximal DTA or isthmus, retrograde type A dissection, distal malperfusion, aneurysmal disease of the proximal DTA, and severe connective tissue disorder in relatively young patient, arch debranching is performed using a Y graft along with an hemi-arch replacement. Care is taken to implant the Y as proximal as possible on the ascending aortic graft so that a good landing zone is available for the future intervention. If there is a tear along the greater curvature, or if the arch is aneurysmal, or the patient has got very aggressive connective tissue disorder and patient is otherwise a good surgical candidate, an endovascular compliant arch placement is performed. Innominate and left common carotid arteries are debranched proximally to the graft. Left subclavian artery is not touched. The proximal arch is replaced with a separate graft and distal anastomosis is made proximal to the left subclavian artery. Anastomosis in this zone has made the life much simpler. Later on, a CT is performed and a stent graft is performed after 2 weeks, and an elective and after 2 weeks. In acute dissection, I usually do not do a conventional arch replacement with a branch graft. With this algorithm, it is possible to operate all morphological and clinical variants, even in a resource and expertise restricted setup with good result. Thank you.
Thank you, sir. So we will begin with Dr. Garish. Again, their topic is TAVR, vascular access and related issues, getting in and out. Dr. Girish.
I think if there's anyone who wants to pass any comment or say something in the meantime.
Yes, we can begin with the discussion.
Yeah. Any questions, comments? Aortic disease, in addition to being a morbid condition, is a very expensive condition to treat. And I think most of us face that as the main obstacle in treating these patients. There's universal consensus on the fact that the descending thoracic aorta or beyond the subclavian is an endovascular treated best. Proximal to that would be a surgical in experienced hands. Several of us who do this are not really doing a lot of total circulatory arrest. In fact, we are able to manage without circulatory arrest, which is the debilitating portion of aortic surgery. Thank you, Dr. Girishu. Please.
Yeah. Once again, I'm here. I'll be talking on access problems that we have and what are the options. Okay. What are the different accesses we have for EVAR or TVAR, as well as where all we can go wrong and where we need to think how to go ahead with your TVAR procedure.
TVAR decreases morbidity and a quick recovery. TVAR has become the treatment of choice for thoracic pathologies. Aneurysm, dissection, penetrating ulcer, transection are some of the examples. Future is low profile devices, alternative access to treat patients with challenging anatomy. 9 to 21% require an alternative access option. So TVAR basically correct site for alternative access varies based on the anatomy, device that you are going to use, region of the aorta you are going to treat. Currently available devices are between 18 French to 22 French. Requires vessel diameter between 6 millimeters and 7.5 millimeters. So what are the alternative accesses we have? Apart from the common femoral, which is the most widely used, you also have the transiliac with the endoconduit. Balloon expandable sheaths are available. You can go transaxillary, transcarotid, transapical, transaortic, and transcaval. Most commonly used is the transfemoral. This route cannot be used when you have an occluded iliac artery, small size femoral artery, or if you have an infected groin. So what is the first choice you have is transiliac if you have a small femoral artery or you have an infected groin. We usually use the common iliac artery if it is adequate size and can accommodate the required device. We would assess this on CT. Anterior transperitoneal route, or you can do a posterolateral retroperitoneal route. You can do it with a direct puncture of the iliac, or you can use a conduit and through the conduit pass your device. A higher mortality as well as cardiac, pulmonary and bleeding risks are there. Retroperitoneal route increases morbidity and mortality. So this is the transiliac access route. You do a posterolateral approach, access the iliac artery, and then you put in about an 8 or a 10 mm conduit and use the conduit as your access, and you can use a snugger so that you don't have a leak around the device. So an endoconduit is basically a balloon fracturing the iliac plaques in an already placed covered stent, ruptures plaques and the artery in a controlled fashion, hence enlarging the flow lumen and allowing the access of the device. Lower incidence of iliofemoral complications, and intravascular lithotripsy is the new kid on the block, where you can access it from femoral. If there is no problem with the femoral, you crack the calcium in the iliac with the intravascular lithotripsy. It gives you space so that your device goes up. So this is the endoconduit. Is basically you have ballooned it, put in a covered stent, and then opened up the covered stent adequately, and then use that as your route to go up into the aorta. Balloon expandable sheaths, unfortunately, are not available in India. They have a small outer diameter upon insertion. Controlled balloon expansion of the sheath you do so that it improves the central lumen of the sheath. It fracture/angioplasty of the required inner diameter to accommodate the device. Solo path by Teramo, only sheath that can accommodate a TVAR, and folded 15 French will expand up to 24 French in diameter. So this is what the sheath looks like. You insert it and then you use a balloon to dilate the sheath, and the sheath does not lose its integrity and expands up to 24 French. Then you have the transaxillary approach.
when the size is similar, which is the size is similar approximately to the femoral artery. You use the deltopectoral groove, or you can use the infraclavicular approach. Access by direct stick or using a conduit, just like we did for the iliac. Landing it in the arch can be challenging, and route of choice for thoracoabdominal aneurysms or on-table fenestration. When you are planning to do a thoracoabdominal aneurysm, you take the device from the axillary and go, or from the subclavian. This is the transaxillary route. We've done it as percutaneous, but you can use a conduit even in this segment. Transcarotid, you use the common carotid artery medial to the sternocleidomastoid. Artery should be free of disease, so you have to do a Doppler before you take the patient up, or you can assess it on CT. Usually used to cannulate fenestrations. More used for TEVAR than for TAVR than for TEVAR due to the large bore, because TEVAR is about 16 to 18 French, whereas the TEVAR is usually about 22 French. Overall stroke rate or TIA rate is high. It's about 6.3 by this route. So this is the transcarotid approach. You have taken an arteriotomy of the common carotid, and then you are passing the device. Transapical, effective for and reproducible alternative access, accommodates any sheath as the left ventricle is straight and uncalcified. Apex usually lateral to the LAD, useful for frozen elephant trunk, and TE guidance is also useful. Transaortic approach, that is again via the retroperitoneal, abdominal, thoracic or sternal. Atherosclerosis can hinder the access. So again, we have to reassess the entire aorta with a good CT to decide if we can take this route. Utilized for aortic arch debranching and antegrade deployment. So this is the transapical route or transaortic route. It's comparatively a very safe. Of course, it is open. And then finally, you have the transcaval route, which is theoretical, but I have not seen anybody use this. Basically, you are going from the IVC, puncturing into the aorta, and then finally what you're doing is you're closing the aortic puncture with a closure device. Thank you.
Thank you for the splendid presentation and good information that you gave to us. Yesterday, actually, one interventional cardiologist had shown transcaval approach. So we saw it yesterday.
But I mean, to actually practically do it is a little scary. It was like when I started doing interventional radiology. Of course, the CT was not there then, and I saw a vascular surgeon doing a lumbar aortic puncture for an angiogram. It's so scary that if I'm not a surgeon to use that route, of course now it's not required most of the time, but at that time to do a translumbar aortography was scary. And the same thing will apply, I think, for transcaval approach.
Just for lack of time, I think we'll have to.
Okay, sure.
Thank you very much.
Thank you, sir. Thank you, the moderators and chairpersons. So we will start with the session 5.2, hybrid aortic surgery. So the journey through aorta will be presented by Dr. Martin Zerny from Germany virtually, and the panelists will be Dr. V.V. Bashi, Dr. Siddhar Rajan, Dr. Gaurav Goyal, and Dr. Varinder K. Sharain. Hello, sir.
Good morning, Martin.
Hi,
Wel-
Vashi, good morning. Hi,
Welcome
everybody.
to-
Thanks for having me. Early here in
Thank you
Europe.
thank you for taking the time. I'm sure it's early morning in Germany. I had the opportunity to listen to many of your wonderful talks in Bologna and many other conferences in Europe. We are very happy that you could take time off this Sunday and talk to our members of the ISCTS and all the cardiac surgeons in our country. We appreciate the time and welcome you to the Ahmedabad meeting. Yeah.
Thanks a lot, and I'm happy to share with you a few thoughts on the journey through the aorta from the root down to the level of the bifurcation, and I have segmented my talk in several components. I will just suggest I'll start, and after each component we'll have a discussion and then carry on. So first. Actually would be a few thoughts regarding acute aortic dissection, how to adequately address the individual clinical scenario. Pathology. These are my disclosure that I'm responsible for the voice, and I'll be ready, but I will start in the meantime. So actually, what it's all about in Dr. Martin, surgery by transcatheter means.
Dr. Martin, if you are a little bit less audible, sir.
As we all know, many of us do. Yeah.
Dr. Martin, there seems to be a
Can
problem
you
with your audio.
hear me? Okay,
Dr. Martin, there is some connectivity issue with us on your side. If you can look over it.
Is it better now? Yeah. Yeah, I will do so. Just 1 second. But my quits.
Martin, there is an audio problem from your side.
So. Now can you now adequately hear? Hello? Yeah, I just heard that. Yeah. Pathology. These are my disclosures. Just another second. Can you hear me now? Is it now? Does it work now? If you can hear me now?
Better.
Hello? Now it works or not? Can you just give me a short... Oh, okay. So can you hear me now? Can you hear me now? Does it now work?
Yeah, Dr. Martin, a bit better.
Okay, it's better now. Okay, very good. So let's start again. So, as said, I will start with a few thoughts upon aortic dissection. So at the end, it's all about the location of the primary entry tear. So let's spend a few thoughts upon, so to say, taking the fingerprints of the disease. These are my disclosures. And I would like to start.
Sorted out, I think.
Yeah. I would like to start with something I would call genotype of the disease. So primarily, the location of the primary entry tear is what it's all about. And as something we do have to realize is that each and every aortic dissection also, besides the antegrade component downstream to the blood, or in parallel to the bloodstream, also has a retrograde component. And the very location of the primary entry tear is highly decisive regarding if a type B aortic dissection remains a type B aortic dissection, as you can see at the left side, because if the primary entry tear is located at the outer curvature, the supraaortic vessels will stand like a kind of anatomical barrier, preventing further retrograde progression. Whereas when the primary entry tear is located at the inner curvature, there's way open for retrograde propagation, causing acute type A aortic dissection. And obviously these cases are not fixed by ascending and hemiarch replacement, which would prevent rupture, but which would not prevent which would not close the primary entry tear. Malperfusion would persist, or in case of non-malperfusion, there would be early diameter propagation, early diameter increase and aneurysmal formation. And actually, this mechanism is not only true for acute aortic dissection, it's also true for intramural hematoma, because actually the majority of IMHs do have primary entry tears, and it's just a matter of adequate interpretation of imaging to locate them and therefore to be able to close the primary entry tear. And I think another important component we do have to realize that acute type A aortic dissections who do present with visceral and renal malperfusion usually do not have their primary entry tear in the ascending aorta. They do have their primary entry tear further downstream. The most proximal tear obviously will be located in the ascending aorta, but actually not the primary entry tear. And this is what we have to realize, because the primary entry tear is the one we do have to close to cure the disease. And we had a look into the German registry for acute aortic dissection and tried to establish a relation between the number of malperfused organs and outcome with regard to perioperative mortality. And so this is a very simple graph, but I think it says a lot, because actually if no if no organ is malperfused, we do have a perioperative mortality of about 12%. This is what we would call uncomplicated type A aortic dissection. And with each and every organ involved, mortality increases by 10%. And if we have a look at this multivariable analysis, so at the end, it's all about the presence or absence of preoperative malperfusion affecting outcome. And so also here, and let me draw your attention to the entry tier in the descending, that the primary entry tier in the descending aorta is associated with a threefold risk for perioperative mortality. And it becomes actually very clear when we make the correlation between this situation and visceral and renal malperfusion, and also the higher extent of fixing the entire thing. And so actually what we thought about in addition was to have a very simple but clear stratification system for naming the main components of acute aortic dissection. And as you all know, the TNM classification from oncology now is valid for more than 70 years. And what we thought is, could we apply the TNM system also for the aorta? And so what we did, or what we defined, is the now so-called TEM classification, where T is type. This is simple. It's either type A, it's either type B, or the non-A, non-B type, where we either have the primary entry tier within the aortic arch, or where we do have a retrograde component of a primary type B aortic dissection, usually via an intramural hematoma into the aortic arch. So things have to be simple, and so we remain from 0 to 3. So 0 is if there is no primary entry tier detectable. So E, that's an next important component, E is for entry, and the location of the primary entry tier and the closure of the primary entry tier is what it's all about. There are cases where there is no primary entry tier detectable. It does not mean that it's not there, but it's not detectable. This would be E0. Then E1 would be a primary entry tier in the ascending aorta. E2 would correspond to a primary entry tier within the aortic arch. And E3 would correspond to a primary entry tier in the descending aorta. And M is, so to say, the metastasis of acute aortic dissection, which is actually malperfusion. So M0, simple thing, there is no radiological or clinical signs of malperfusion. M1 refers to the proximal thoracic aorta, in other words, to the coronaries. M2 refers to the supraortic branches, and M3 refers to all downstream organ systems, being the spinal cord, the viscerals, the renals, and the extremities. And a small plus would be added if, in addition to the radiological signs of malperfusion, there would be also clinical signs. So this is, so to say, the Euroscore of acute type A aortic dissection. But as you know, we do not also not only need a kind of Euroscore, we also need a kind of syntax score to anticipate the complexity of the individual clinical situation. And several of you might be aware of the so-called Gerada score, the Gerada registry. And out of this registry, we designed a preoperative risk score, which you can access by the homepage of the German Society for Thoracic and Cardiovascular Surgery, whereby very simple clinical and radiological components, you're able to anticipate risk. You can calculate preoperative risk in a few minutes by focusing on these simple parameters like age, sex, resuscitation before surgery, previous cardiac surgery, the preoperative state, the presence or absence of malperfusion, as well as the extent of aortic dissection. So let's have a few clinical examples for that. First example would be an acute type A with a primary entry tier in the ascending aorta with no organ malperfusion. So it would be a type A E1M0. In other words, the nice acute type A, the uncomplicated type A. And if we take our parameters of a 50-year-old patient and insert these parameters into our web calculator, then we will have a predicted mortality of 9%. A second example where and actually you can all go to this homepage and play with these components and see how which component affects the severity of anticipated perioperative mortality. Another example here would also be an acute type A with a primary entry in the ascending aorta with supra-aortic malperfusion. So type A, E1, M2 plus, because our patient also is clinically symptomatic. And if we insert these parameters, we do have a predicted mortality of more than 20%. So this corresponds to what we have seen at the very beginning, that with each and every organ system involved through malperfusion, mortality increases by 10%. So another example, another escalation of the situation at type A, with a primary entry tear in the ascending aorta and visceral and renal organ malperfusion, also clinically. So at type A, E1, M3 plus. This patient has a predicted mortality of more than 30%, which also corresponds to our simple graph where each and every organ system involved increases mortality by 10%. So in other words, the TEM classification extends the Stanford classification with regard to the site or the type of dissection, the location of the primary entry tear, and the presence or absence of malperfusion. And corresponding to that, the Gerada score is a simple and effective tool to predict 30-day mortality in patients undergoing surgery for acute type A. So the combination of the two provide a unique tool like a kind of Euroscore as well as syntax score for acute type A aortic dissection. And this now leads us actually to the treatment strategy, because the fundamental principle is always the closure of the primary entry tear, either by surgical resection or by transcatheter closure. And so ascending and hemiartery placement might not be enough in about 20% of cases, because the primary entry tear is not located in the ascending aorta. And so application of the frozen elephant trunk technique, which is for sure nothing for each and every acute type A aortic dissection, but might be conceptually needed to reverse malperfusion in about 20% of cases. Now let's have a look at a classical CT scan of the patient where the primary entry tear was located at the distal aortic arch with visceral and renal malperfusion. You can see true lumen collapse here. And ascending and hemiartery placement would prevent rupture, but it would not reverse malperfusion. So this is the classical example. We can count the erythrocytes through the adventitia. We can see the circumferentially detached intimal medial cylinder. And this is an aortoscopy where you can see the primary entry tear distal to the level of the left subclavian, a very smooth intimal surface. And so the short version of the frozen elephant trunk will be enough to exclude the primary entry tear from circulation and to fix the entire disease. And this is the postoperative CT scan of this patient, which shows the so-called domino effect, meaning stabilization of the membrane throughout the cardiac cycle by closure of the primary entry tear, and all downstream segments are stabilized by this approach. So let me spend a final word about addressing the entire thing. As you can. Sorry, guys, I have to remove the tone, so we are fine again now. So actually, what I would like to share with you here is just a very simple component of the operation, and this is the case if you need aortic root replacement. And if we do aortic root replacement, we always use the sinus of Valsalva prosthesis because it has several advantages. I will just shortly want to highlight. If we do root replacement, replacement using a biovalve, and then we take the given diameter of the valve, which was 27 in this case, and you simply add 3 millimeters, and then you have the perfect size of the sinus of Valsalva prosthesis. And usually you just have to fix the valve to the prosthesis at the level of the commissures, and actually that's it. And actually there are two decisive advantages when following this conceptual approach. The first one is that reattachment of the coronaries is easier because the sinus bulges, and you have more flexibility with regard to the reattachment of the coronaries. The second one is that the level of the height of the reattachment of the coronaries is very clear, because you don't have this you don't have the effect of distension when pressurization of your valve conduit, if what you would have if you just use a straight tube. And the third advantage is, in case there is need for secondary TAVI in the years to come, the coronaries are far away from the level from the struts, and so TAVI after aortic root replacement, or even after valve-sparing aortic root replacement, using a sinus of Valsalva prosthesis has a major advantage, because distance to the coronaries and space for reinsuring sufficient antegrade flow into the coronaries will never be an issue if you use this conceptual approach. So concluding the first component of my talk is, it's all about the location of the primary entry tear and the extent of the disease. Always have in mind that each and every aortic dissection has a retrograde propagation, and this retrograde propagation starts at the level of the primary entry tear. And this knowledge often helps you to locate the primary entry tear. And in case of visceral and renal or extremity malperfusion, it's very likely that the primary entry tear is not located in the ascending aorta, but in the distal aortic arch and the proximal descending aorta. The TEM classification harmonizes terminology and helps in planning treatment by simple clinical and radiological components. And the Gerade score is the first of its kind as a web-based tool for standard use to predict mortality, and the combination of them are Euroscore as well as syntax score of acute aortic dissection, and fingerprinting aortic disease improves understanding and helps to anticipate and determine the treatment strategy. Thank you.
Thank you, Martin, for a great presentation. I think this classification looks very practical, and to predict the mortality. One question I want to ask is, what is the duration of the presenting symptoms to the treatment in your experience, in your place?
It's a very good question, because it's different according to the region and actually to the setting. So our mean time difference between onset of symptoms and initiation of surgery is 5.2 hours. So it's very short in our setting. So as we all know, if patients have severe malperfusion from the very beginning, there's a high early attrition rate. We do not see that we get all these cases, because this time frame still allows them to be transferred. And sometimes these patients are in a devastating clinical condition with sky-high rates of lactate. And for instance, if you're located in other regions where the emergency chain is less developed, you will not even get these cases because the time frame between onset of symptoms and therapy might be 10 hours, might be 2 days. And then this early attrition rate of the sickest ones has already happened. So it's pretty short in our setting.
Okay, because we get patients from geographical distribution is such that it's difficult for patients to reach the hospital very early. So a few of the patients come maybe sometimes after 12 hours or 24 hours. And very rarely we get patients at such a short time. So anybody has got any other questions?
Any questions from the audience? Yeah. Yep.
Any situations where the native aorta in say ascending aorta acute dissection, the native aorta can be preserved by just lateralizing the flap. When can that be done, and when not to do it?
If I got the question right, you're referring to the extent of repair according to the location of the primary entry tear, right?
Yes, if the entry tear happens to be in the ascending aorta with no organ malperfusion, can the native aorta be preserved?
I hear you. So actually, absolutely. So the main principle we are following is detecting the location of the primary entry tear and exclusion by resection. So in other words, we always do an open anastomosis, so always hypothermic circulatory arrest with selective antegrade cerebral perfusion in each and every case for also arch inspection, but ascending and hemi-arch replacement are sufficient in about 80% of cases because it will cure the disease with regard to the origin of its disease, and we do not overtreat. So in other words, there are protagonists of very liberal, for instance, frozen elephant trunk implantation. In each and every case, we do not do that because we are pretty convinced that this is overtreatment. And we would prefer in these kind of scenarios to have secondary elective surgery because our experiences in secondary elective surgery replacing the aortic arch by using the frozen elephant trunk technique are very good with a low mortality and a low stroke rate. I will refer to that in the next segment of my talk.
Thank you.
Hi, guten Tag, Martin. Can you hear me?
Yeah, yes, I do. Excellent.
I just wanted to know, is this a proposed classification? It sounds very, very exciting and very logical. Or is it already in place in your center or in Europe?
It's in place in several centers in Europe. So actually, the next round of expert consensus documents and the next round of guidelines will all already implement TEM as well as Gerada score. The only component what the Gerada score, TEM does not refer to is the extent of disease. So what we thought, and this will be the next add-on, is that we should combine TEM with the Ishimaru zones. Because, for instance, you say type A, E1, M0, but it doesn't tell you anything with regard to the extent. So it is so the disease process could stop at the arch or could go down to the iliacs. And if you would now add the Ishimaru zones saying 0 to 9, you simply know it starts in the ascending, obviously it does because it's at an acute type A, but it goes down to the infrarenal. Or if it stops at the distal aortic arch, it would be Ishimaru 0 to 2. And so the combination of these would truly give you a very simple and pragmatic initial concept of what is going on and what to do to exclude the primary entry tear from circulation, which is all about.
Wunderbar.
Good. Excellent German. Good.
Any other questions?
No, sir.
Yeah, if there are no more questions, we'll go to the next part of the talk, Martin.
Okay, my pleasure. So just let me sort myself here. I will have it in a second. So there we are. So let's continue our journey through the aorta and now remain at the level of the aortic arch. Again, my disclosures. And here you can see what we did in the last year with regard to the distribution and variety of cases we treated. And as you can see, thoracic aortic pathology involving the aortic arch has become a major component of our entire setting. So also here, let's start with a few thoughts regarding the underlying pathology. So this is now an aortoscopy of a patient undergoing total aortic arch replacement using the frozen elephant trunk technique, which has multiple penetrating atherosclerotic ulcerations, in other words, obliterative arteriopathy. And as you can see here, the devastating consequences atherosclerosis.
Dr. Martin,
yeah.
Can you share the screen, please? The slides are not there.
Okay, sorry.
You will have to start with the screen sharing.
Yes, sorry, I'll do so.
Yeah, thank you.
So just give me a second to get this going. So, okay, excuse me, now I'm back again. Very good. Okay, so there we are. Yeah, good. Okay, so here the aortic program and what we have been doing last year. And as you can see, patients with thoracic aortic pathology affecting the aortic arch now form a major component of our entire program. And so also here, let's start with the underlying pathology, because I think it's so important to understand what is going on and to have this link from imaging to tactile feedback. And actually, this is what it's all about, or that this is what is the luxury of surgery, because our interpretation of imaging varies from all other specialities, because we do have the disease in our hands every day. So this is an aortoscopy of the descending aorta in a patient undergoing total aortic arch replacement using the frozen elephant trunk technique, which has disease on the basis of atherosclerosis. Yeah. So in other words, this is obliterative arteriopathy. I will try to run the video again. And obviously, irrespective what you do, the risk of detachment of debris is very high. And this is independent if you choose open surgery or endovascular techniques. Obviously, open surgery here is better because you can have remote cannulation, cooling down our patient and touching the disease at the time when we are in hypothermic circulatory arrest. Let's have another aortoscopy of a patient with post-dissection aneurysmal formation. So our patient here has already undergone ascending aortic replacement during acute type A. The primary entry tier was not closed during initial surgery. We just switched with the aortoscope from the true to the false lumen. Here you can see a large primary entry tier which remained open during primary surgery. And obviously here, irrespective which strategy you choose, the remaining risk of embolization is down to zero, because this is a fundamentally different disease process. This is dilatative arteriopathy with a very smooth intimal surface and no risk of detachment of debris, because there is no debris there. So always understand what you treat, and this understanding and interpreting the disease process forms a major component of the surgical strategy to choose. And obviously the frozen elephant trunk implantation has become a major component of the treatment of the aortic arch. And this simple scheme here shows you already a very important detail, and this is proximalization of the descending anastomosis into zone 2. So the left, we always use the quadruple branch version of the prosthesis. We cut the LSA of its origin, but we leave the tissue in place. And therefore you proximalize the descending anastomosis from zone 1 into zone 2, from zone 3 into zone 2. And this simple technical trick has eased the entire operation fundamentally, and it provides perfect exposure with regard to the ease of accomplishing the anastomosis and also with regard to hemostasis. And so I would say the overwhelming majority of surgeons in Europe now use this proximalization technique of the distal anastomosis into zone 2. Here a short glimpse of how we perform the procedure, always right subclavian cannulation, always with a side branch. Many of these operations in our setting are redo procedures, currently more than 50%, because we aim for what we would call proximal full fix, to have the root at rest, to have the arch at rest for further downstream, to have perfect conditions for further downstream aortic repair, either by open or by endo. By having accomplished the distal anastomosis in zone 2, we restart rewarming, we reimplant the left subclavian, we reimplant the left common carotid, and then we usually address the root in case the root has to be addressed. Also here, you have seen a sinus of Valsalva prosthesis. Then we open the clamp, let the heart beat, and finally then reattach reattach the brachiocephalic trunk at the very end when the heart is already beating, because then it's easier to judge the distances when there is already a pressurization. So this is what we have been doing in the last few years. And here you can see the distribution of underlying pathologies. And now let's have a look at the results according to the underlying pathology. These are the results in patients with penetrating atherosclerotic ulcerations. And if you remember the aortoscopy we just have seen together, it becomes very clear indeed that these are the ones who have the highest stroke risk. We do have a stroke incidence of 15% in this cohort, but eventually, when you reflect how atherosclerosis affected the aortic arch and the descending aorta, it becomes very clear that transcatheter techniques would even be associated with a higher stroke rate in this sickest cohort of patients. So, and if you just reflect our second aortoscopy with the post-dissection aneurysmal formation, these results here become very clear. In patients with type B and type non-A, non-B aortic dissection, because stroke rate is very low, as is in hospital death, because this is dilatative arteriopathy. There is no possibility for detachment and embolization. So this is the best subgroup of patients undergoing total aortic arch replacement using the frozen elephant trunk technique. And this also relates to this Kaplan-Meier survival curve, which is actually excellent. One thing you do have to keep in mind, and you do have to discuss with your patients in advance, is that there is a frequent need of secondary intervention. And so at the beginning of our series, this was an observation, and now it has become a strategy. So what do I mean by that? We just use the short stent graft version of the frozen elephant trunk prosthesis. And the main reason for that is actually the circumstance that we have reduced the remaining risk of symptomatic spinal cord injury to a very, very low single-digit number by just using the short version of the prosthesis. But this implements that many patients will need secondary extension. And we have now performed about 80 patients where we had planned or unplanned secondary distal extension of the frozen elephant trunk prosthesis by TVAR. And we did not observe a single case of symptomatic spinal cord injury when following this concept, because we always do it the same way. We do have CSF drainage in all patients. We monitor motor-evoked potentials, which gives you a limited ability to react in case potentials go down or the latency gets longer. And so this is a very, very stable and safe concept. Shortly ago, I mentioned that we prefer to better have secondary elective total arch replacement as a strategy, preferring to having a frozen elephant trunk for all, a concept for all in acute type A. And these are now our results with the frozen elephant trunk technique after previous aortic surgery. Also here, we have a very low in-hospital mortality, and we have a very, very low stroke rate. So I can just recommend to have a very selective strategy in acute type A. Just, I know I'm saying this now for the 20th time, but you cannot overemphasize that. Just focus on the presence and the location of the primary entry and just focus on the closure by surgical resection or TIVA, because everything else you can do later on. So also here, survival after previous aortic surgery is very good, but also here, very clear, there is a substantial rate of reintervention. But as said, by having CSF drainage in each and every case, by monitoring motor-evoked potentials, the remaining risk of any collateral injury during secondary TEVAR extension is very low. Eventually, one component already here, we will come to that shortly later. We do not do open surgery just from the level of the frozen elephant trunk technique. We always have TEVAR extension down to the level of the diaphragm. And then what remains to be done in an open fashion is done in an open fashion, because after several years taking care of these patients, what I have learned in open thoracoabdominal replacement, don't touch the left lung. This is one of the key components of having successful open repair. And by downstream shifting of the disease by TEVAR implantation, you reduce thoracoabdominal replacement to a kind of 3.5 repair. It's not not a definitive type 4 repair, but we would name it 3.5, and this definitely reduces collateral injury of these operations. So another now and as you know, you can do the entire operation also by transcatheter means, by using the relay branch system, which is a modular system with a main body like a standard TEVAR prosthesis, hosting a window for the supraortic branches, and then you do have to come from both carotids for the implantation of the bridging stent grafts. This is a case showing multiple penetrating atherosclerotic ulcerations at the level of the aortic arch, which has been a very suitable case for total endovascular aortic arch repair. So here it's all about the details of anatomy, and this starts with at the level of the excess vessels, because the excess vessels have to host a 24 or 25 French sheath. The detail is that the ascending aorta or an already implanted ascending aortic prosthesis has to have a length of at least 7 centimeters measured by centerline measurements, and it should be straight. So in case of ascending or also emergency acute or the ascending aortic replacement, eventually already anticipated secondary endovascular aortic arch repair could be an option for this patient in the years to come, and always take care that the ascending prosthesis is at least 7 centimeters in length. If this is possible, there are situations where it's simply anatomy does not allow that, but if it does, it should be done, and that the prosthesis is straight. So this is the conceptual approach. We have the main body. The main body hosts a window, and this window hosts 2 sleeves where we connect the bridging stent grafts. The setting we do have here is a 1-to-1 copy of our TAVI setting. So we use rapid pacing for blood pressure lowering during deployment of the main body. We do come from both common carotids for implanting our bridging stent grafts. We do already have the option of a triple branch graft, but the majority of patients is still treated by a double branched approach, where we revascularize the left subclavian, and we do this in each and every case, not for left upper extremity perfusion, but for preserving inflow into the posterior cerebral and cerebellar system, as well as for preserving inflow into the spinal cord. So here you can see the opening of the main body, and now we have unobstructed free flow to the head and neck vessels, and all the time we do need to cannulate the sleeves for implanting our bridging stent grafts to the brachiocephalic trunk and to the left common carotid artery. So we usually start at the right side, and we cannulate the posterior tunnel hosting the bridging stent graft for the brachiocephalic trunk. You always have to be very clear that you are within the tunnel and not outside, because this is possible. So we just have a contrast filled balloon inflated to reassure that. And then the first bridging stent graft is implanted, as you can see here. And this is followed by the implantation of the second bridging stent graft coming from the left common carotid artery. And this is the conceptual approach. And as you all know, the ones of you who work by transcatheter means, success or failure is determined during planning. And if you have adequate planning, then this is a very smooth and straightforward procedure where the combination of left common to left subclavian artery bypass implantation as well as branched endovascular artery repair can be performed in 3 hours, and this is the completion CTA. So let's have a look at these results. So these are this is an early series because I think currently we do have about 200 implants worldwide, and we collected the cumulative experience of 6 centers here, sharing 43 cases. We had a mortality, perioperative mortality of 9%. The disabling stroke rate is acceptable, but as you can see, the non-disabling stroke rate is definitely too high. And we do have to have every effort to reduce this to a minimum. I think we could spend the remaining of the day discussing mechanisms of symptomatic and neurological injury after this prosthesis, but de-airing is a component. This is very clear. But remember our toscopies we shared at the very beginning. It's all about understanding the disease process. And in this kind of these severe atherosclerotic lesions, transcatheter means should simply not be applied. And now when we talk about subgroups, we have let's have a look here at patients having undergone a branched endovascular artery repair with remaining aortic dissection, also reflected the aortoscopy we have seen. This is the best subgroup because they don't have atherosclerosis. And as you can see here, no perioperative mortality and 1 non-disabling stroke, and that's it. And obviously, this is the most favorable subgroup for this technique. And I think this is also the focus group in the years to come. So outcome after branched artery repair is good. Disabling stroke is low, but non-disabling stroke is definitely too high. And we do have to apply as much input as can to reduce this to a minimum. And best outcome is seen in patients with remaining aortic dissection, and obviously more data are needed. So concluding at the end, and I think this is the main message of the entire talk, pathology determines the mode of treatment. The frozen elephant trunk technique has excellent results. The results of total endoartery repair are promising, but the stroke rate has to be kept in mind and has to be reduced with all our efforts we have. And at the end, the creation of aortic centers with the entire armamentarium will aid in doing the right things in the right patients. Thank you. So, Bashi, I can't hear you. I think you're muted.
Dr. Bashi, any comments from your side, sir?
Yeah. Thank you, Martin, for a very nice presentation on aortic dissection and its management. It's very clear, because why I want to thank you is because dissection aneurysm treatment is picking up in a very rapid pace in our country. Among the younger surgeons have taken it in a very big way, and number of cases are increasing. And you have given a correct, lucid explanation of what is to be done. I think the take-home message of today's talk for us, I feel, is in a dissecting a type A dissection, or where the entry point has to be tackled first. And then if you are experienced in doing only, depending upon the case, you should do extensive operations, because from your results itself, you have shown that reoperations does not carry much additional risk in experienced hands. So that's a very valid point, because most of the time, one has to decide what is to be done in a given case, which definitely is the secret of success. Because in a difficult case, you try to do an extensive procedure, you can land up in trouble. It's better to have a live dog than a dead lion. To send the patient home should be our first time, and that is one of the best messages. And very nice results with all your large experience and variety of cases. It is very overwhelming, very lucid talk. Thank you so much. Is there any questions you have? Anybody from the audience?
Any questions from the audience for So I guess that will be all. And
yeah, thank you once again, Martin. We look forward to seeing you again.
My pleasure. We'll do so. All the best.
thank you,
Bye-bye.
Dr.
Thank you,
Martin.
thank you,
Thank you, Bashi sir. And we'll conclude. Thank you.
So moving on to the next session, session 6. The chairpersons are, the sixth session will be innovation in cardiac sciences. The chairperson are Dr. Devang Desai, Dr. Vishal, Dr. Ritesh, and moderators are Dr. Kishore, Dr. Jayesh, and Dr. Harshad. And we will start with the topic TPVR, what, when, and how by Dr. Muthu Kumaran. Hello, sir. So you have to unmute your audio.
Can you hear me now?
Yeah, sir, we can hear you.
Okay.
You can start, sir.
A very good morning to all, and I should especially thank for the organizers for inviting me to this nice meeting. And I'm so happy to be around. And my topic is going to be a transcatheter pulmonary implantation: what, when, and how. So these are disclosures of mine. Moving on, the background. Actually, the prevalence of congenital heart disease in adults is growing a lot in India. We started with the congenital heart surgeries actively from 1998, 2000, and it's about 20 years down the line. We are seeing more adults growing it, and our prevalence is growing in adults. And out of all this, 20% of all anomalies, aortic anomalies are the main, and they have significant PR at 2 years post. And pulmonary replacements based on RV dilatation and symptoms, surgery is often delayed due to and a lot of morbidity involved. Delayed surgery can cause irreversible RV dysfunction. So these are recommendations of surgical pulmonary implantations, meta-analysis of different papers. On what commonly agree is looking for the end diastolic volume. It is more than 150 to 170 ml per meter square. RV dysfunction, your PR severe, and you have any prolonged QRS duration. This is taken into consideration, and this is based on surgical recommendations. I'm going to the paper published in 2000 by Philippe Bonhoeffer, which revolutionized the entire valve program. The first valve to be implanted in a human, the percutaneous pulmonary implantation, when the patient came with a very dysfunctional RVOT, he stitched a valve to a stent and then implanted it. And this formed the basis for the old valve implantation program we are seeing now. So this is the device and delivery system. What Philippe Bonhoeffer device is a bovine jugular valve stitched over a stent and taken over an ensemble system and implanted. This is the first custom-made pulmonary valve being introduced in the system, and after that the TAVR started. So you can see there's a severe pulmonary regurgitation, and after the valve implantation, there is no pulmonary regurgitation. This sort of revolutionized the whole process. So moving on, there's sort of introduction about pulmonary valve implantation. What are the valves available now? We have got two set of valves, balloon expandable and self-expandable. Self-expandable valves are used in RVOTs less than 27 millimeters. If you look for Melody, is less than 23. And the valves available are Melody, Edwards, Sapien, and MyValve. And self-expandable valves, two are available in the market: venous P valve and Harmony valve, which can go up to an RVOT of 36. So, so pulmonary stenosis is severe and moderate. You can differentiate. With severe stenosis, regardless of symptoms, we have to go for a pulmonary implantation. If it's suitable, we go for transcatheter or we go for surgery. Moderate PS, we look for symptoms. If there are poor symptoms, then we go for a valve implantation. If it's regurgitation, we look for symptoms again. If the symptoms, we have to go and replace the valve. If there is no symptoms, we look for the RV end-diastolic volume, look for the RVEF, look for the systolic volume, and also look for the QRS duration. Taking into consideration all these things, we form a plan for anatomy of suitability of our pulmonary implantation and go for a valve implantation. So contraindication to pulmonary implantation, basically coronary compression, where we open a balloon across RVOT, go to the maximum and look for any coronary compression. If there is any coronary compression, we have to send the patient for surgery, any active infection. So this is the most common anatomy, which is 80% of all, which is going to be a huge RVOTs, which you got transannular patch, and that's the major challenge we have. So the currently available valve for here in India is venous P valve, where it's got a central cylinder, expanded proximal and distal portion, and comes to a 16 to 36 mm diameter, and been done mostly in China, and we have been using in India also. Here we do angiogram first, and then go for a balloon dilatation and the balloon sizing in RAO and LAO view. We size it, and based on that we choose the valve, and then we go for implantation. This valve looks like, as if silk portion and extended. One important aspect is there's a lower RVOT stenting is involved, which prevents the RV remodeling, and that's a major setback of this device. And also there is stent fractures have been reported with this device. Ideal pulmonary valve should be the diameter of 20-27. So that's something we should consider if you want to do early pulmonary implantation. So how can we build expandable valves use huge RVOTs? We can do a hybrid procedure where surgeon reduces the PA and we can implant a valve, or we can do a MP reduction by a lot of devices being trialed and is being under trial still. Stenting from one of the branch PA, forming a landing zone for melody valve. We just send from RPA or LPA and form a landing zone and put a melody valve. That's something we described. So the experience in India, we're going to just tell you about the MyValve experience and also what we have done so far. So it's the first transcatheter pulmonary implantation done in India, which is Indian valve, which we published in a couple of years ago. This is a lady who had 3 surgeries for a petrolifallo valve implantation. She had severe mediastinus. At the time, we decided not to intervene for her. We have to do surgery. On follow-up, she developed severe RVOT obstruction, for which I did a stenting of the RVOT. She developed severe PR, and she wanted to get married. At this time, we have been involved with MyValve in transcatheter aortic position. So the first time we used MyValve in this situation, we used 23 mm MyValve. We dilated the RVOT, that stent to 22 mm balloon, and then took the MyValve. And then we expanded the MyValve there in the position. You can see that the MyValve there, and it comes up to fully. Once expanded, it starts to function straight away. So this is the most common. This is one of the easiest variety where we have conduit, where we can put a valve. There's good opposition. There'll be there's some calcium available. So there is we can implant, put a stent, and implant the valve straight away. This is the commonest. This is the most least by 20% of the population. But the majority are having huge RVOTs. What are we doing with them? This is a lady who presented with 59 years old with retrograde up to 10 years of age. She had 2 children and has been lost to follow-up. She presented with 65, breathlessness, palpitation, EC fatiguability. And we found out she has severe PR and RVOT was 28 mm, but surgeons refused because she had LV dysfunction also. So this is the point we started to define the landing zone. We're looking for narrowest point anywhere in the pulmonary artery. So what is that? Here is the MyValve introduced a 30 mm valve, which is a boon for us because the largest available valve at the moment in the world is a MyValve 32 mm. So we defined the landing zone. We found a narrow zone on this lady, which comes around 28 mm. So we thought we should be able to put a valve there. So this is a type valve transcatheter pulmonary implantation plan we have for a native PA. We do under general anesthesia. We access right into interjugular vein, right lateral artery for the anesthetic access, right femoral vein, primary access for the valve, left femoral vein for IV angiogram guidance, right femoral artery for LV pacing. I don't have any pacing catheter in RV because when you push this the big sheet across, you may dislodge the pacing. Pacing very important for implantation. Left femoral artery for the coronary interventions or coronary angiography. So the hardware, the list of hardware what we use, most common ones, most important ones are the covered stents and stent graft in case we have rupture. and you should have pacing catheters and coronary stents if you want to intervene urgently. Linterquist wise, one important wise, you keep it there because one supports you to get the valve across. Sound French guide, I tell you why we use sound French guide for that. So this is the procedure being done. We do an angiogram RAO 3030 and a lateral one, and we can see it's a severe PR and dilated RVOT, huge pulmonary artery. There's some certain narrowing we have seen at the patch level. So here we use the technique with a sound French guide to anchor the Linterquist deep inside LPA. The Linterquist takes two wires in. One is your thermo wire, and over that you take a Linterquist and slowly push the Linterquist over it, and the tracks, the sound French guide tracks down deep below and gives a good position. So once it's there, then what we do is we go for the balloon sizing. This is a more crucial step. We use a Z-med balloon. We open it up across RVOT at the maximum. We look for a waist and do a simultaneous RV angiogram and a coronary angiogram. There should not be any flow across RVOT, and there will be a tight fit, and there should be a mild narrowing also. We measured this 28, so we upsized to 32, 4 mm more. That's what we recommended initially. So we went for a sizing, very slow inflation. We take a lot of time. We do injection first initially. Halfway through, we do one more injection. We pace the heart so for the whole procedure at around 200, so that we don't valve doesn't move. And then finally, we position the valve across and go for the full inflation. And we also do a coronary shot, making sure the coronary is normal at the end of the procedure. We keep a wire in the LAD because that's the one closest to your valve, and there's no obstruction to the coronary arteries post implantation. And you can see there is no pulmonary regurgitation post implantation. This is the first case I did in about 2 years ago, and following that, we done around 15 cases so far. This is on-table extubation. She will ward in 2 hours, and then discharge the next day. She's doing well. Her AF regressed, her RV is regressed, and she's completely asymptomatic. So this is an initial experience we published in our Annals of Pediatric Cardiology. We indexed 3 cases, and you can see the data of them. They always had a high end-diastolic volume of the RV, and the QRS duration was prolonged, and severe PR was there. And we actually looked at the angiogram balloon sizing and the CT scan sizing compared to the final valve procedure, and we found a correlation with balloon sizing rather than a CT scan. So once you balloon size, you know exactly how much is the resistance going to be offered. Over the balloon sizing, we recommend around 23-25% maximum, the minimum to get the valve across a good position. If you don't have that, the valve can embolize. So the minimum diameter you should have on balloon sizing should be around 29-30. If you have anything more than that, we cannot do. So my valve and pulmonary position, 15 cases in standard conduit and 9 cases in ATPA. This is an early multi-center experience where we used my valve in stented RVOT with good results. And now what we do now is, if anybody wants to transcath the pulmonary implantation, large dysfunctional RVOT, we do a CT scan first, look at the landing zone. If there is no landing zone at all, there is very narrowed RVOT, we go for a surgical or a hybrid pulmonary implantation. If there's landing zone, we go for a MyValve or a Sapien, depending on the RVOT. If calcified nose RVOT, we require pre-stenting, and we go for a MyValve, Edwards, or Melody, whatever is available. So in summary, there are growing number of post-op patients needing pulmonary implantation. Surgicals this is a good, although morbidity is very high. The availability cost of valves from abroad is a concern. Defining the landing zone by CT-MR is a crucial. MyValve up to 20-30 mm can be safely implanted with good initial outcome. The native PA doesn't need stenting if he has got a good association. One question I've been asking myself is, should we really wait for the RVOT to get more than 30 mm? Should we redefine a criteria based on RVOT, which I am starting doing already to offer the patient? If the RVOT is growing more than 24, we ask them to go for a valve implantation because they lose the chance for transcatheter pulmonary implantation for a balloon expandable valve. Thank you for listening. Thank you.
Thank you, sir. So we will take questions now. Any questions?
So you said that there is a if obstruction is in the deep, below the RUOT, then you do hybrid
Yes.
procedures, surgery as well as. So is it, are you doing this frequently, or it's
now we are doing more and more now. Whenever patient presents with this post-radiology fellow obstructed RVO, we stent them first with CP stent and we go for a valve plantation. In case where we have a patient with large, huge RVOTs, surgeons do a submammary incision and go for a plication of the pulmonary artery. Then we go for a valve plantation straight away. That's why planning. That's what we're doing at the moment.
Okay. Thank you. Anybody?
Thank you, sir.
Thank you very much. Thank you, guys.
Thank you. So we'll start with the next presentation of Mr. Gaurav Parchani on artificial intelligence in cardiac science.
Thank you for having me, everyone. This is a bit different talk than what you've been hearing since yesterday and today. I come from technology background, and my topic is talking about artificial intelligence in healthcare and the advances that we've seen in the last few years, particularly. I'm representing Dozy, which is one of the companies that are working in health tech and patient monitoring and triaging systems and warning systems. And I'll discuss about the solution as we keep going ahead. So before we discuss the solution, a small glimpse of the problem, and this is nothing new. Most of you being in healthcare already know about this. In our country, the healthcare system has been burdened for a long time, even pre-COVID, and COVID just expanded all the cracks and even amplified it way further. In our countries, in different parts, we have nurse to patient ratio ranging from 1:12, 1:15 to 1:40 even. On the other hand, WHO recommends that in a high dependency unit or in a step down unit, you should have at least 1:4 ratio. For specialist to patient ratio, we have something around 1:5,000, which is essentially translates to for 55 million cardiovascular patients in India, we just have 5,000 or so cardiologists, 50 of them almost here today and yesterday combined. Every year we add few hundred cardiologists to our, to our manpower or to our doctor force in the country, and every year we add millions of cardiac patients as well. So this gap is very disproportional. This is something which leads to our healthcare infrastructure being broken, and this is, as I said, this has been there for a long time. It's an infrastructure issue. And this is not something which is getting really better. Although we're establishing more medical colleges, we see more and more cardiac surgeons, cardiologists, different specialists coming up, more nursing power that is coming to our manpower or workforce in the country as healthcare professionals. But these numbers are getting worse. Why? Because as simple as we have For example, we have approximately 2 million hospital beds in our country, both public and private combined. In the next 5 years, we've decided to double these, but we don't really have the manpower to man these beds. We are definitely going to double the infrastructure, the number of hospitals and the number of beds, but we're not going to have enough humans or healthcare professionals, both in terms of doctors and nursing staff, to actually cater for these beds and these patients. And in this time, we have to look at the problem a little differently. We have to see how technology can help here. This gap that is ever widening, can technology help bridge it? And if yes, how? So artificial intelligence plays a vital role in essentially aiding or actually automating a lot of efforts that are manual in nature, that can be automated, and then the healthcare professionals or the humans in collaboration can focus on the care, compassion, and actually the intelligence part of it. One such solution, and this is just one such solution, we have multiple solutions across different companies and different researchers that we've seen. For example, artificial intelligence in imaging particularly taking up really well in the last decade or so. But we decided to look at it in a different manner, right? We thought, we went into remote patient monitoring, and this is where one of the solutions that we came up with was to the problem that monitoring right now is very manual. Of the 2 million hospital beds that I spoke of, only 100,000 hospital beds, 1 lakh hospitals, 5% of the hospital beds are just ICU beds where you have continuous monitoring available, a 1:1 or a 1:2 nurse to patient ratio, where there is a continuous or critical care outreach being carried out on a daily basis or on an hourly basis. On the rest of the beds, we have different protocols in different parts of the country. In some cases, we have the nurses taking manual spot check readings every 4 to 6 hours. So we have 4 readings or 6 readings per patient. During your rounds, you would just see on a piece of chart paper that these 4 points marked out. Our theory is that this is nearly not enough for critical care outreach. It takes a lot of time. We've done a time, as in a time analysis, and taking that, it takes 7 minutes per nurse on a particular patient to complete the set of readings, put it on a paper and file it in a file. So 42 minutes per patient per day is something which is very high. Can we automate this process without major intervention from the healthcare professionals and major intervention from the patient itself, so that we can ensure the compliance is higher? So we've designed this product that goes under the mattress. It, in a contactless manner, collects vital signs, heart rate, respiratory rate, heart rate variability, even blood pressure to a certain extent now, and basically feeds all of this data into an early warning score engine, which is AI powered and which decides to escalate any sort of alerts to the healthcare professionals in time, so that an intervention can be triggered, whether it's shifting to ICU, whether it's shifting to whether the patients are at home, whether it's triggering an intervention for a consultation, and so on and so forth. This is how the data looks like, and that is how the patient looks like. So all the patient that he or she needs to do is just sleep on the bed, do nothing else. There is no compliance required as such. And all of the data on the left-hand side is something that is available to you remotely. Whether the patient is at home, whether the patient is inside the ward, you can access the data at any point of time whenever there is an alert triggered from any remote device that you have, your laptop, your smartphone, and it's very easy to handle. This is the science behind it as well. So the science is called ballistocardiogram. Ballisto is movement, cardio is heart, graphy is measuring. So it's essentially measuring the movement of the heart. This is a very old technique. This was actually invented in 1877. But a lot of people lost interest in BCG after ECG came in 1903. Primary reasons, there's a lot of noise in data. The data is not that standardized. So it's not really that useful to me, is what the healthcare professionals at that point of time thought. But in the last 2 decades or so, with the advancement of machine learning algorithms, digital signal processing, and computation power that we've seen on the cloud, we can now harness this data on a continuous basis without an intervention or without a person looking at it all the time 24/7. A machine can look at it and trigger if there are any anomalies or abnormalities that we find. We essentially extract the cardiac signal as well as the respiratory signal out of that, and then we carry on with multiple set of analysis to figure out multiple information, non-contact blood pressure, even to a certain extent. You would see in the coming slide the research that we're working on. We've just launched this. So we've been present in over 5,000 hospital beds during COVID time. We've monitored more than 60,000 COVID patients in these connected HDUs, connected high dependence units, where hundreds of hospital beds inside the ward are being monitored by a central location inside the hospital by a couple of healthcare professionals. And this is how the critical care outreach was being driven in these hospital beds. And of these, almost 60% of these beds are in public facilities as well. So we've proven that technology, if made properly, can actually go in remotest of the solutions or remotest of the places and can create a difference. We've been able to trigger early warnings or early intervention in these COVID wards for more than 3,000 patients, where they were triggered either for an ICU transfer or given oxygen on time or given a ventilator support on time. But now we're launching this connected heart care or cardiac care program, which you would have actually seen on our stall yesterday and today as well. The idea is that the patients after a significant cardiac event, a heart failure event, or any event that when they're post-discharge or when they're discharged and they actually go home and they're still not at their baseline for the next couple of weeks or next couple of months, they can be put under continuous monitoring and a daily triage can be triggered every day. Based on the daily triage, there can be interventions or escalations that can be delivered to you after full investigation has been done with the facility of a 12-lead ECG and other sensors like temperature, blood, NIBP cuff, SpO2 sensors, all of that data being combined together and being given to you on time. And the patient can actually be readmitted on time before a second event or a second major event occurs. All of the data or all of the care command center happens remotely all over the cloud. So all of the data is actually available to you at any point of time, whether you're traveling, whether you're in your clinic, or whether you're in your hospital, at just your fingertips on your smartphone or on your laptop. The basic or the major part behind this program is essentially an AI engine that keeps on crawling through all of the patient's data, establishes a personal baseline for that particular patient, and keeps monitoring that patient. Whenever the data of that patient or vitals of that patient leave their baseline or go beyond the baseline, there is a triage that is done and the patient is categorized either into green zone, amber zone, or red zone. And that is when an intervention is triggered. All of this obviously comes with a lot of concern that we're moving a lot of this sensitive health information and data to cloud, and whether it's secure or whether it's private enough or not. We've taken major steps to ensure that it is. Just in last month, we've been certified ISO 27001, which stands for Information Security Management Systems. So our systems are very secure, and we've taken care of all data privacy guidelines that are available. The data is very secure, and only with authorized credentials, only and only then you can actually get access to all of the data. The data ownership belongs to the patient in case of the home care, and to the hospital and the doctors in case of hospital care. This is one case study that I would love for you guys to see. It's a couple of minutes of video. This is one of the first case studies that we did in our home, as in our cardiac connected care program at home. When and I would love to play this video, but this is a case study where a 60-year-old lady got the device for her 80-year-old mother, who used to stay alone and was adamant on staying alone. And to track their vital signs and as in to track their health, she had tried multiple sensors, multiple variables, multiple times, multiple solutions. But Dozy fit perfectly there because of its non-obtrusiveness. It went under the mattress. It did not change the lifestyle of the person at all being monitored, and did not bother them at all, but still was able to trigger for an event. I'll just quickly play this.
It's been 5 years since my father passed on. And the only regret I've had in life so far is that I haven't been able to spend time with him. I thought I'd do that with my mom, but she didn't want to change things and preferred living alone. So I was always looking for a way to ensure that my mother is okay. And Dozy helped me achieve that. There is no stopping my mom when she sets her mind to do something. She'll do everything without thinking how working so much will affect her health later. So that's why I got her Dozy, so I could keep track of all her vitals without disturbing her. With the updates I was getting from Dozy, I knew everything was fine with my mom. But one day, I got an alert. When I asked her, she dismissed it. She said maybe I was just working a bit too much, but I couldn't ignore it. So I spoke to my doctor and he said we could run some tests on her. Thank God we did the tests. The reports revealed that she had some abnormal heart rhythm and she required a pacemaker to set it right. The doctor said we were lucky to catch this so early because even a minor delay in that situation would have been catastrophic. And Dozy gave me what I wanted most, more time with my mother. I sleep peacefully now, knowing fully well my loved ones are always safe with Dozy.
And a fun fact in that video, the characters that you saw were not actors. They were actually they were real people that were using Dozy, and all the characters were kind of it happened, and we're very thankful to them that they wanted to come on camera and give this testimonial to Dozy. There's another case study where we've affected more than 800 successful transfers in one hospital alone. And this was one of our first installations during COVID in IGGMC Nagpur, where we converted more than 150 hospital beds to step-down ICU beds in their connected HDU, spanning across 6 wards. The daily triage that happened in the morning, the reports that were created out of these 150 beds, which beds are high risk, which beds are moderate, and which patients are low risk patients that were identified. Patient rounds or doctor rounds were structured accordingly. And early interventions were triggered based on alerts that were raised by Dozy. And these were almost 800 in approximately 8 to 9 months of time. Not only this, we've even worked with the Indian Army. There was a temporary hospital that was set up in New Delhi, which was called SVBP Hospital. We were given 3 days to set up or convert 300 of these beds into step-down ICU beds, and we did it in 2 days. And we ran a full demo for them on the 3rd day. So Dr. Madhuri Kanetkar, who gave us the task, actually gave us a big compliment as well, that Dozy, her doctors could sleep because Dozy never sleeps. And this is just the beginning. We've right now established Dozy well in the category of general vital monitoring, patient monitoring, and a basic early warning system or a triaging system that identifies that something is going to be wrong in the next few days or in the next few weeks. And there is a lot of investigation or a protocol that you would need to follow in your general, how would you follow in normally if a patient would directly come to you. So essentially what we're moving towards now in the next few years, and we've already stepped a foot forward on most of these projects, is essentially going deeper into each space. Cardiology is one of the very important spaces to us. So a couple of research points that we're working on. I already mentioned a non-contact blood pressure that we're working on from the vibration data. Second, we're working on a heart failure project with AIIMS Jodhpur and Jaydeva in Bangalore, where we are trying to estimate the cardiac output non-obtrusively, non-contact from under the mattress even, which is where we're looking at the trend of the cardiac output. So let's say if a patient is at home post a heart failure event, we could track the trend of the cardiac output in every day for a few weeks and look at the trend accordingly. We are also working with some hospitals on sleep apnea to estimate the apnea-hypopnea index during the night of patients. Sleep apnea is severely underdiagnosed in the country. And the idea is that we can enable easy triaging and screening for that so that we could identify more and more undiagnosed cases before they come to you. Beyond that, we're also working on touchless arrhythmia detection as well with a few hospitals and a few doctors there. And the idea is that moving forward, we have to reimagine healthcare. A sleep apnea test that looks like on the left should look like on the right. as I mentioned, screening for heart failure, a lot of places in our country do not have access to an echocardiogram. In a lot of rural areas, the nearest echocardiogram is 100 kilometers away. Can we enable smart screening and identifying and bucketing people in the category of, let's say, grades of heart failure, so that we can escalate them to the nearest facility to confirm? Beyond that, people who are already at home would not every day go and do an echo test to estimate their cardiac output. So can we do that on a daily basis without bothering them or without changing their life cycle or lifestyle, and ensuring high compliance in the process? Non-contact blood pressure monitoring would actually change ambulatory blood pressure monitoring to something like which is on the left to something which is like on the right. Arrhythmia tests. And the moral of the story at the end of it is essentially that we cannot do this alone as technology. We have to come together, healthcare professionals, along with technology, along with policymakers, along with hospital administrations, and we have to do this together. If we have to leapfrog and solve for the load or solve for the scale that India is. Thank you. Any questions? Okay.
Thank you.
Thank you, Dr. Guru. Mr. Guru, sorry. So now we will start with Dr. Nikhil Prashu's presentation on my experience with next generation thin strut BRS mesh res 100. Dr. Nikhil Prashu.
Good morning. Well, good afternoon, friends. It's great to see you all coming here on a Sunday morning as well. I'm going to talk briefly about, it's not a new innovation, but you may call it so, because we are used to putting metallic stents in all our patients who deserve to be treated because of blocked coronary arteries. And the technology is in layman's language, you can talk about a dissolvable or absorbable scaffolds, which is completely opposite to the metallic stents. So we have come to know or come to realize or come to accept that is DES, which is drug-eluting stents, the holy grail of PCI. That means we cannot do without metallic stents in PCI. Well, we have to think about it again. We have learned to live with this. We have learned to live with putting metallic stents in patients' coronary arteries, with consequences of what we can see here. The eosinophilic infiltrates, delayed healing of the vessel, because we basically are ballooning the vessel first, creating a lot of injury to the endothelium, dissections, microdissections. So there's a delayed healing, there's eosinophilic infiltrates, there's a vessel remodeling happening, and a consequent neoatherosclerosis. Well, you may say, or you may argue, but this is all to do with the first generation or second generation metallic stents, which is giving rise to delayed target vessel failure because of all this thing happening inside the vessel. Well, wait until you see the 5 years outcome data of metallic stents. You can see Resolute versus Zymes, and you can clearly see that despite beyond 1 year, the target vessel failure keeps on happening. up to 5 years. And this is a major problem which we have realized. And that is why we have been recommending to continue giving patients dual antiplatelet therapy beyond 1 year and putting them at risk of bleeding from mostly gut. So we now have come to realize that target vessel failure, very late stent thrombosis is a real problem beyond 1 year and up to 5 years, as shown in this slide. Let's have a look and compare what happens to the coronary artery from inside when we put a metallic stent versus when we put a absorbable scaffold. You can clearly see from the left-hand picture that the metal stent is seen, and inside the stent you can see neoatherosclerosis, which is a new restenosis happening, as compared to, you can see the absorbed treated artery on the right-hand side, which gives you what we call a golden yellow tube. You can understand that when you have a drug eluting from your scaffold, it can also treat what we call a disease in the vessel, and it can make the vessel disease-free. It's completely different from what we call about using a scaffold or to keep the artery patent after angioplasty. This is a new concept here. If you can see what happens to the artery when we treat it from inside with a balloon and a stent, you can see clearly the remodeling happening over from 6 months to 5 years. And this, if we are lucky, then it comes in our favor, means human being favor. But we are unlucky, then we have seen eosinophilic infiltrates, neoatherosclerosis, late stent thrombosis, very late stent thrombosis, and what we call ultimately target lesion failure. So if we look at absorb 4-year outcomes, we quickly realize that the target vessel failure keeps happening over 36 months, with the difference between Zymes, which is a metallic stent, versus absorb, which comes worse in case of absorbs. If you look at the absorb 4-year outcome, again, in terms of definite or probable stent thrombosis, we realize that stent thrombosis is the one which is a huge problem in absorb scaffold. So we know that the concerns with first generation BRS, and you can see from 0 to 30 days, in case of absorb, the device of thrombosis is a huge concern from 1.5% to 3.3%. And this is a huge problem when we try to put absorb scaffold in arteries which are less than 2.25 millimeter in diameter. But it's not such a problem if we put this absorb in an artery which is more than 2.25 or 2.5 millimeter. So this could be the vessel size related, because absorb is a bulky device. So we have found that these problems could be device related, procedure related, or patient related. So BRS specific implantation strategy reduced 12-month scaffold thrombosis rate from 3.3% to 1%. So what was that strategy? You can quickly see here the target lesion failure when you see the absorb without PSP. PSP means you have to treat the vessels before putting the stent in with a very aggressive predilatation with a non-compliant balloon or a cutting balloon or a rota, or doesn't matter what it takes to really dilate the artery before you put the scaffold in, followed by a very aggressive post-dilatation. When you do that, you quickly realize that in the green, absorb with PSP, there was no more increased TLF as compared to metal stent. Similarly, stent thrombosis again disappears when you use a PSP technology or technique. So despite better patient and lesion selection in absorb 4 compared with absorb 3, adverse outcomes still tended to be greater with BVS than with metallic stent. So despite using a bigger artery, despite using PSP, we realize that still absorb fare badly as compared to a metallic stent when we looked at this. Specifically, improvements in device technology was needed, which was thinner struts. Our metallic stents are 80 to 90 microns as compared to absorb, which is 150 microns. So clearly we require an improvement in this. So improve the technique or patient selection is PSP, do the angioplasty with imaging and a prolonged DAPT. But we have to make the struts thinner as compared to absorb. and improved mechanical properties in terms of how we can take our device to the lesion. And bioresorbable scaffold outcomes, why technique matters. We have seen why technique matters because you can reduce the stent thrombosis and both TLF when we use PSP. So patients following initial phase, we know that these many problems were seen when we retrospectively studied our patients. So some things emerged with our new technology of thin strut BRS of 100 microns achieved by a company called Merrill, which is made in India, this technology here. And we saw that we should not be using in initial phases in tortuous vessels, in small vessels, in calcified vessels, in CTO, and in complex multi-vessel disease in the first phase. So improve the device. So BRS under siege due to bulky first generation. So we have achieved it by reducing to 100 microns. And then we can clearly see this technology, new technology, which is MERIS 100 microns. The crossing profile is lower as compared to absorb is 1.2 millimeters. The markers at the end of the stent are clear with 3 radial markers there. Size matrices are different. You can see specifically that there is no scaffold at the moment available below 2.75 millimeters. So that to stop us, the cardiologists, from putting these devices in arteries below 2.5 millimeters. And of course, they can be kept at room temperature as compared to absorb, which had to be refrigerated. So this is what the MERIS 100 looks like with improved 100 micron thickness, which is lower. Crossing profile is better. There's a hybrid closed and open cell design of this. There are 3 radio opaque markers at the end. You can see both ends, which are clearly visible. You can see this, that it dissolves or absorbs over 3 years. Within 6 months, the molecular weight is lost, the loss in radial strength, change in crystallinity, and drug is eluted. This all happens within first 6 months. And you can see from day 0 on the top left-hand corner to 3 years, no strut or no scaffold is left, and the artery is clean. And again, the patient's own artery with no metal inside is left. So you can see the difference between absorb and the MERIS 100. You can see on the left hand and the right hand side with a strut thickness of 150 microns in absorb and 100 microns in MERIS, which is a huge advantage and improvement in the technology. You can also see the radio opacity of the markers in case of MERIS 100, which clearly says proximal markers. 3 radial markers can be seen very clearly, and the 3 distal markers are seen clearly. This is very important because you have to choose the size and the length and appropriately deploy the strut, the device at a particular point. Not only that, when you try to put the scaffolds one after the other, then you don't have to really overlap them. You can put exactly kissing each other. So this is what it tells us how to do that in terms of distance between the markers and the scaffold is 1.3 millimeter. So there is still some scaffold beyond the markers. And I'll skip that very quickly. This is how we line up. When the distal and proximal markers are overlapped, that means the 2 scaffolds are barely kissing each other, not overlapping each other. Because overlap means 100 plus 100, 200 microns, and we don't want to do that. So this is how we line up and kiss the 2 scaffolds together with no overlap. These are size metrics. As most important thing in size metrics is they have provided us quarter in sizes, because we know the scaffolds cannot be overexpanded beyond 0.5 millimeters. And that's why it's very important to choose the scaffold, even in quarter sizes here. It's very important. Now, the clinical program is very extensive, and it has been presented, the trial data all over the world, has been published extensively as well, and has been shown to be effective, safe, with low stent thrombosis and low TLF as well. And we also have a long-term clinical outcomes with that, with no increased stent thrombosis or target lesion failure. So this second generation of BRS technology holds great potential for future PCI if we can use it properly. I can show you, if this plays very well, what it means to really predilate the lesion appropriately. So this is a patient. You can see that in the LAD, there is stenosis there. I treated the circumflex as an acute event, but you can see the LAD has a tight focal stenosis, what we thought was a focal stenosis, but it was not a focal. I chose to do an OCT in this patient before even touching the vessel, because that gave me information about the morphology of the lesion, length of the lesion, and diameter of the lesion, so that I can choose one-to-one balloon size of non-compliant balloon. And one-to-one is not lumen one-to-one, because angiography we can see the lumen only. We don't see the vessel wall. But here we see the vessel wall, which tells us to choose the balloon as per the vessel wall and not as per the lumen. And that's very important to prepare the lesion. And we then pre-dilated it, put absorb into it, and again did this before putting an absorb here. So we again did the OCT to understand exactly what is the length of the scaffold we're going to choose and what is the diameter of the scaffold we're going to choose, one-to-one completely. So this is how the imaging guides us. And after putting the scaffold, we do another post-dilatation and imaging to tell us that imaging optimized outcome of this. So this is how we put this thing, and OCT we did that. That was again, and you can see the vessel wall underneath, how big it has become. And you can see wherever our marker is moving on the angiogram or on this thing, you can see the cross section with square blocks of absorb or mirrors. You have to see that this is put in, and a circular image we have got with no geographical miss. We are very sure that there are no dissections at the proximal distal edge. We're very happy that we have achieved an excellent image in terms of full expansion. And we know that this is how this patient is not going to come back to us with a target lesion failure or stent thrombosis. This is a problem we faced in absorb with the distal markers. Are very difficult to radiologically see it, and very difficult to mark to overlap each other. But I have shown you in new mirrors that how beautiful there are three radical markers. We have to overlap the balloon with the scaffold marker so that they're barely kissing each other. This was very impossible with BRS. And then again, we see this, that how we have achieved this with OCT guided and OCT optimized image. Thank you very much.
Thank you. Yeah, Dr. Nikhil, I have a couple of questions. I mean, as we all understand, I mean, what happened to absorb stents, I mean, all of us are very well aware of it, because all absorb was being launched with a lot of hype, and it came and it went. I mean, even it was being banned by FDA. So I think the new stents which you are saying, the absorbable stents, the thing I could understand is different in the sense that it is thinner than the previous one, like the 150 to 100 micron or whatever you said. So is it the only difference is in the thickness that makes the difference? And the other thing I just want to ask you, can you use this for the primary PCI? And number three, would you recommend OCT in every patient whenever you are using this absorb?
These are three brilliant questions. I'm glad that you raised these questions. I can tell you what happened with BRS and absorb in the initial phases. Absorb was a completely new technology and a brilliant technology. People who promoted it and people who used it both did not know how to use it. It was, the new technology was invested heavily into it by the Wall Street. So they wanted their pound of flesh back as quickly as possible. So to say, how absorb was going to be used and how much and where it went into people's hand who were dealing with finances only from Wall Street. So they guided the company to use it as quickly and as much as possible without giving any details to how it should be used. And only when we retrospectively analyzed, we came to know that there is a huge problem with acute stent thrombosis when the patients are dying. There's a huge problem of target lesion failure with major adverse cardiac events. And we realized that why it was happening. It was happening because we only knew how to implant or deploy metal stent, and this was not metal. So we clearly found out, and there are now publications from different operators, different groups, and different registries. Mainly one of the ones from Korea is a brilliant registry, which clearly showed that device clearly is too bulky, of 150 microns. Number two, our technique where they found out in outcome data of absorb all the trial that not all the patients underwent pre-dilatation. Not all the patients underwent post-dilatation. And any lesion was chosen as if it was a metal stent, like calcified lesion, bifurcations, left main, you name it. And they quickly realized that vessel size was also important. Any vessel size was more than 2.5 millimeter. If a patient has undergone all the three in terms of pre-dilatation, appropriate size choosing, and post-dilatation, there's no difference in the outcome in stents, metal stents, or even absorb. There was still some difference left. So it was decided that despite using all these techniques and avoiding patients of below 2.5 millimeter vessel wall, calcifications, left main stem, still there was some more stent thrombosis and this in this, which are clearly reduced to 150 microns. So this addresses that, and they are very careful in not allowing us to put this in below 2.75 vessel. That's one.
But most of the proximal lesions or proximal vessels are bigger. So I mean,
yes,
you end up leaving the proximal, and the atherosclerosis happens in the proximal lesion.
Absolutely brilliant. So actually, they also have a tapering scaffold available to us at the moment, which they have not released it, but they are going to. So at the moment, they are doing exactly correctly. They want us to choose type A lesion. They want to choose shorter lesions, and they want us to choose no bifurcations, no calcifications. And when registry, they're collecting the data throughout. When the registry they are very happy with, then they will release longer tapering scaffolds. They will allow us to bifurcation. And I think this is how it should be done. Your question about, can we use this in STEMIs? Yes, we can use it in STEMIs. And I'm using it in STEMIs in my institution. I have experience of putting BRSS for a long time. And I have now experience using this device in only type A lesions so far. But I have used this in STEMI patients as well, as long as we do not have a very huge thrombus burden. We don't have very long lesions. So this can be used very readily in STEMIs as well. Yes. Thank you.
What about OCT? Would you recommend OCT? Maybe?
Brilliant question. We do not have OCT or IVUS available in all institutions in India. The penetration is hardly 2% or 3%, I believe, as compared to Japan, where every angioplasty, including metal stent or no metal stent, is done only through imaging. That's the difference between different geographies. As long as we are very careful in choosing our vessel size, and I know experienced operators like you are extremely good at choosing the vessel size very carefully, because they don't know finish slot. They've been doing it for a long time, and they've realized that not all patients require OCT or IVUS in real practice. So yes, this technology can be used without imaging by an experienced operator who knows how to choose the size correctly.
The last thing, I mean, are we running a double-blind randomized trial? Because unless you have it, you are not going to convince the rest of the world, because it's made in India. I mean, whatever the bias people have, the Western world especially, for us or against us. So it'll be difficult for us to convince the rest of the world that, okay, this is something which we have really discovered and we are really going to tell the people that use it.
MERIS has been undergone a very good clinical outcome trial. Just like when Absorb was used against their own Zion stent by Abbott. Similarly, Merrill has used MERIS 100 against their own metallic stent, which is again everolimus stent. And they have shown the outcome data clearly is as good as their metallic outcome data in a large trial. And they have a whole clinical program, which has been presented in TCT, is presented in EuroPCR, and has been published now as well. So MERIS 100 now is available all over the world and is being used.
Thank you. I wish you all the luck.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Nikhil. Next, we will start with Dr. Claudia's presentation on CT fusion technology with 3D echo, moving step forward.
Hello, everybody. You all can see my screen, hopefully. Yes, perfect.
Yeah.
Okay, well, thank you very much for having me to this event. My name is Claudia Lacerda. I am part of the global team of GE Healthcare ultrasound imaging. And I'm going to present to you a novel technology called CT fusion and what are the new aspects of fusion imaging in structural heart interventions. So first of all, let's look into the clinical background. And before going to showing this technology, I think it's important to have an overview about the structural heart market trends. And indeed, it is a market that has been growing for the last several years, and it's expected to grow even faster in the future. The number of devices available on the market continues to rise, and the complexity of the procedure is also increasing. It's very true that we are seeing this world as being a multimodality imaging world, where actually the CT imaging is an industry standard in performing complex structural heart intervention. So CT has really a key role in those procedures, and we will see that why later. And it is very true for all TMVR and TTVR procedures that are upcoming in the market. So as LA closure, where actually CT imaging is used for planning the procedure and precisely size the device that will be chosen for the procedure. Let's have a look on the role of imaging in structural heart interventions. So fluoroscopy is actually still the reference image for the interventional cardiologist. It provides high resolution of visualization of the devices and the catheter. Whereas echo has become a key player in those procedures because it actually provides the assessment of the structural heart defect. So we will look into the anatomy, we will look into the physiology, we will look into the severity of the regurgitation, and everything will be assessed by echo. Then echo is also the imaging technology that will help you and will allow you to confirm the sizing done on CT. But if the sizing is done on CT, then the day of the procedure, when we start the procedure, we will do an echo. We will start with a TE, and then we will do other measurements that will try to confirm and compare the sizing with what was performed on CT. It helps also to actually guide catheter advancement and device implantation to really ensure acute assessment and position and deployment of the device. And then at the end of the procedure, we'll still evaluate the success of the procedure and investigate for possible complications. But what about the CT? Well, the CT actually provides a clear visualization of the anatomy and allows the physicians to understand better the relationship between the structure and understand better the anatomy of the patient. It is also used to plan the whole procedure. So everything is planned on CT. All the devices that are upcoming in the market that are full TMVR or full TTVR procedures, they will be using CT to plan the procedure, to plan the catheter pathway, but also to size the proper device, to plan the position of the catheter, and to plan the orientation of the C-arm. It will also allow you to assess and characterize the existence of calcification. So CT is a very powerful tool to actually have this big overview about the whole anatomy and what we are expected to have and the desired position of the device in that patient. But let's have a look also on these challenges. So we saw a little bit of the trend of the structural heart market. We saw the role of the imaging, but what are the challenges? Well, those are very complex anatomies, so they really require extensive planning before the intervention. It is important to understand the entire anatomy that is specific to each patient to actually determine the best access route, properly size the device, and also plan the CR. All the steps that we'll be doing and every assessment that will be done before the procedure will actually help to go faster and to have a better overview and to actually know what we are expecting during the procedure. Then it's a very complex navigation that is required. So we need to have improved intra-procedural imaging to guide device implantation and to perform the pre and post assessment. And actually having access to multimodality imaging that we can leverage in the cath lab would be key for some of the procedure. Indeed, if we are planning everything on the CT, why should we bring that information within the cath lab? So that's why we believe that fusing CT and echo could be very valuable to actually bring that information within the cath lab. Those are also high-risk procedure, and they require to shorten procedure time, to decrease radiation, and also to increase accuracy and safety for better patient outcome. So indeed, if we prepare better, if we plan better, and then if we use this planning information during the procedure, it's like basically going to a place, a CTA from a CTB, and bring your GPS with you. We all do that today. We bring our GPS when we go traveling. So if you do your procedure, you should also bring your GPS, which in this case will be the CT information. So that's why GE Healthcare has developed a tool called CT Fusion. So CT Fusion allows you to actually get the CT data that we use to plan the procedure within the echo scanner. And by importing the CT, which can be any type of CT, since this is a vendor agnostic solution, you can get the CT on the scanner, align the CT according to the pictograms that are shown here on this little video, then place the landmarks on the CT and save that within the scanner. Once this user has done that, you can also have a 3D imaging, and then you will align it exactly the same way and place the exact same landmarks within the echo image. And you can have a co-registration and a fusion between echo and CT. But let's have a look on clinical examples on why this technology and how this technology can help in the future. Here is a example of an LAA closure. And if I get my laser pointer here, well, this is here an example where you actually have those white dots over there within the CT data. Well, those white dots are actually the planning information and the planning that was done on CT. So usually there are several software available to do planning on CT. There is a very well-known software called Fremantle, and we are actually able to read the planning data sets, the planning information that is burned on the CT within the scanner, meaning that we can have access to the proper transseptal puncture location, but also here you will see the landing zone of the device. And having access to this type of image allows the physician to actually know better the orientation of the catheter towards the LAA. And if you can see over there, this is only within the region of interest that is delineated here in blue. This is only the region of interest of the visualization of the echo, which means that the CT also provide an extended field of view for the better assessment of the anatomy. Then if you look into here, this imaging here, you will see that indeed we do have the information of the landing zone of the device right there as delineated on the CT. And then here live on the echo, we can definitely deploy the device and define the same landing zone is according to the CT data. We don't have this type of information today. We didn't have this type of information today in the cath lab directly. This information was lost when we were getting in the cath lab. So bringing that information, make sure that indeed the device will be well deployed within the right and correct landing zone. And after the case, well, we can redo a fusion and make sure that in here you see the device is already in place, and make sure that indeed we do have the device well in place and well settled as expected, and that it is a correct position. Let's move on to another, to another example. Here is an example of a cardioband. So cardioband is an annuloplasty procedure that can be both mitral and tricuspid, and it is a device that is CE mark in Europe from Edwards, and it's still not FDA cleared, but there are trials undergoing. And basically, the user has to put several anchors. It can be 15 anchors, more or less, around the annulus. And those anchors are tied with a band. And once the last anchor is put in, then we will squeeze the band so we can reduce the size of the annulus and increase the coaptation of the leaflets. Here you see specifically an example why CT fusion can help in this type of procedure. This procedure can be very challenging and very time consuming. Since it could be very difficult to actually place all those anchors, and to make sure that those anchors are in the correct location, in the correct orientation, it is important to have the CT information. If you can see here in the CT data, we do have some white cylinders. Those are the correct and desired location of those anchors. And if you look into here on the echo imaging, well, you can make sure that indeed the catheter here is placing the anchor. And if you look into the comparison and the co-registration with the CT, we can ensure and assess that indeed the anchor was positioned in the right location and also right orientation. Whereas here in this specific example, you see that here that the anchor is supposed to be placed here. Well, we did place it in the right location, but if you look into the trajectory and orientation of the catheter, well, the catheter should be a little bit more vertical, as here it is assessed and planned here on the CT data. So it really allows the physician to make sure that we are in the right location and to correct the orientation also directly on the fly, because this will affect also the position and the orientation of the other anchors that can affect the final outcome. So it's very important to be on the right location and on the right orientation. Let's have a look on another procedure. This is a Tendyne procedure. Tendyne procedure is a device, a transapical, a mitral full replacement device that is actually set through a transapical puncture. It is a device that is also CE mark in Europe, but still under trial and not FDA cleared yet. And it can be also a very challenging device, because nowadays those type of devices and all TMVR devices, the most difficult challenge and the most worrisome actually concern of physicians, it's about neo-LVOT obstruction. And this tool, CT Fusion, will allow you to actually check in different steps of the procedure that you are actually in the right position, in the right location. So let's have a look on why and how it can be very useful. Well, here, this is the first image before the procedure starts. Usually, CT data are done way in front of and way before the procedure starts. So we do have a lot of times, most part of the time, CT data that are done 1 month before the procedure starts. Those patients are very sick. So we are planning an intervention and sizing of the device on a heart that is very sick, and the day of the procedure that the anatomy may change a lot. So it's very important to actually be able to do this fusion imaging to make sure that the anatomy has not changed and that it is still the same. And if we do have a perfect match, as we do have here in this first image, well, we can then confirm the size of the device and make sure that, yes, okay, the anatomy hasn't changed, so we can move forward with the device that we had selected based on the CT data. Then over there below, there's an image here with those red arrows. I'm not sure if you can see it here, but there's on the 3D imaging over there a little image over here that shows you the finger poke. So basically, when we are doing this type of procedure, we do a transapical procedure, and the surgeon, so you need to have a surgeon for this type of procedure, an intervention cardiologist, and they are actually with the finger going into the apex and doing those finger poke and looking into the echo to make sure that actually they are in the right location to do the transapical puncture. However, they are only basing this assessment based on echo. So it's very important also to have the overview of the echo of the CT below and to make sure that indeed the finger poke is in the right location. So that's why in this specific step, it's very important actually to be able to fuse the imaging and to have the CT information below. Once the device is deployed, so basically we are going up until the mitral valve, and then we open the device, and the device is placed on the annulus. And then there will be a plug being connected to the apex. What is very challenging, and you can see those two images are the same actually. This is a biplane imaging, and this is the fusion of the echo 3D dataset with the device implemented and the CT. Over there, what you can see is that with biplane, after this type of the procedure, when you deploy the device, there is so much shadowing, there are so many artifacts that it's very difficult to visually assess if there is an LVOT obstruction. What is done today is that we actually put a gradient and measure a gradient over there and check for any obstruction through the gradients. But it's definitely very important to have a visual confirmation of whether or not we do have a neo-LVOT obstruction or not. And here, when fusing that data set, the 3D data set with the CT, well, we can definitely looking into it and see that indeed there is no obstruction because we have used the same CT that was valid in the beginning of the procedure. And then right now we are looking into it and see that indeed there is no obstruction there. So it's another tool to really assess for the success of the procedure. And I did several cases where indeed before releasing the device, we were assessing the position of the device there and then make sure that it was well in place. So as a summary, interventional cardiology is actually really a multimodality environment in which CT has a leading role in procedure planning, and echo and fluoroscopy are really instrumental in real-time guidance during the procedure. And CT Fusion, it's a solution that really allows you to bring the planning information within the cath lab. It allows you to register and co-align CT data with 4D echo imaging, which actually may lead to create this real multimodality environment within the cath lab, which is very needed for all upcoming devices that will be commercially available very soon. It provides an extended field of view of the anatomy to better understand the anatomy itself and the relationship and the anatomical relationship between the cardiac structure, and allows you to confirm the planning in the CT and also to improve device positioning, to confirm correct positioning and minimize peri-device leak. Thank you very much for your attention.
Thank you, Dr. Claudia. We can have some questions, if any.
Anybody in audience?
Yeah.
So just I want to ask you, is it the real-time technology? I mean, you're going to fuse the images real-time, the CT as well as the echo? And if it is, then, I mean, who is going to be, primarily doing it, the radiologist or the cardiologist? And because most of the cath labs are not equipped with CT scans. So how are you going to manage that?
Yeah. So the CT is not live indeed. We are collecting the CT from the radiology department or from the device company that actually has done the analysis on the CT. We actually use one of the phase. Usually we use the diastolic phase to have this information. So indeed the CT is not live yet. And it's actually imported within the echo machine that will be used for the procedure. And then it will be up to the cardiologist or the echo imager to do all the fusion live within the cath lab and directly on the echo scanner.
Thank you.
My pleasure.
Thank you, Dr. Claudia.
Thank you very much.
So next we will begin with Dr. Kamlesh Kotawade with Impella. How can we increase clinical applications?
Good afternoon, everyone. So thank you, Dr. Naik, for giving us an invitation. So my name is Dr. Kamlesh Kotawade. I'm working as a medical director for Asia Pacific for Abiomed that makes Impella device. And I'm going to provide very high level overview of how this technology is about, a little bit on the hemodynamics and mainly the indications for this device. So coming to the company, Abiomed is not a new company. We are 50 years old company, and the first device that we had is AbioCore, which is a total artificial heart, and we got US FDA approval in 2005. And then we have series of products like BVS and AB5000, but the real success for us has come when we have Impella technology back in 2007 time, and after series of clinical trial data and randomized controlled trial, we got it US FDA approval in 2015 and 16 time. And latest in the series is Impella 5.5. So these are our product portfolio. So we have Impella 2.5, and as per the name, it gives you 2.5 liters of flow per minute. We have Impella CP. CP stands for cardiac power. That gives you 3.5 liters of flow per minute. Impella 5.0, that gives you 5 liters of flow. And all these three are the left-sided devices. We have Impella RP. RP stands for right percutaneous, and it's a right side device is used for right heart failure. And as the flow increases, the insertion size also increases. For example, for Impella 2.5 is 13 French insertion. For Impella CP is 14 French, and for Impella 5.0 is 21 French, which means it has to be inserted through through axillary artery with a surgical cut down. So this is the animation of Impella, and you can see how it is inserted through femoral. And the insertion is not that difficult as long as we are good with managing the large bore access devices. And it fits well into your LV, and it unloads your left ventricle, sucks the blood from your LV and pumps it actively into ascending aorta. So it's an active pump, and it has a motor that rotates at certain RPM, creating a suction effect. And this is your Impella RP, which is for right heart failure, is right side devices. It is inserted through vein. And unlike left side Impella, which has impeller, this has a propeller. So it pushes the blood from your IVC into your pulmonary artery. And then we can have axillary approach also. So for Impella 5.0 or 5.5, which are larger bore devices, so ideally it has to be inserted through axillary artery with the help of vascular surgeon. And the good part about axillary approach, you can actually ambulate the patient. So this is the technology that unloads your left ventricle and provide excellent coronary perfusion. It provides excellent end organ perfusion, and it can also provide the right side support. So patients with biventricular failure, you can put both sided Impella right and left, and it's called bipella. And it helps with the early ambulation and early recovery. So coming to the indication, so we have two distinct indications for this technology. So one is used for short-term use in protected PCI or high-risk PCI, used commonly by interventional cardiologists. And what will be the ideal patient that fits for this particular indication? So patient who has multiple comorbidities, patient who has hemodynamic compromise, or patient who has complex coronary anatomy. So ideal patient would fall somewhere in the middle to get Impella for protected PCI. And on the right side, you can see this is a cardiogenic shock indication. So irrespective of the cause of the shock, whether it's a AMI cardiogenic shock, whether it's a cardiomyopathy, whether it's a SCAD or peripartum cardiomyopathy, or the myocarditis, including the COVID-19 myocarditis. The post-cardiotomy cardiogenic shock and the mortality with this condition is very high. And then as a bridge device, a bridge to durable LVAD, or as a bridge to transplant, or bridge to recovery, or bridge to decision. So all of these are the indication for Impella. So US FDA approved indication for Impella in cardiogenic shock is up to 6 days of support for Impella 2.5 and CP, and up to 14 days of support for Impella 5.0. You can see on the right side of the screen, this is the death spiral in cardiogenic shock. And as patient progresses into the late stage of the shock, when patient lands into multi-organ failure, at that time, putting the device, your outcome may not be that good if you use this device at early stage of the shock. So using this device in the right patient at the right time is very important to get the best outcome. Because time is a muscle when it comes to cardiogenic shock. And so we encourage to use this device as early as possible to get the best outcome, which has been proven by multiple clinical trial and registry data, including the National Cardiogenic Shock Initiative by Dr. Bill O'Neill from Detroit. So this is a crucial slide that talks about the hemodynamic of the device. So you can see that, as you can see the arrow on the screen. So this is the outlet of the device, which is in your aorta. And because it actively unloads your left ventricle and push the blood into ascending aorta, it increases both the flow as well as the mean arterial pressure. And lately, in the last 8 to 10 years, there is a one terminology which was used in multiple shock trials, which is cardiac power output, or CPO. So cardiac power outputs is nothing but the product of your flow and pressure, that is your cardiac output, multiplied by mean arterial pressure divided by constant, which is 451. So every effort should be made to keep the CPO above 0.8 to get the best outcome. And it has shown that CPO is the predictor of mortality in patients with cardiogenic shock, whereas the cardiac output or the mean arterial pressure independently, they are not the predictor of mortality. So CPO is very important, and you can see that how Impella helps to increase the CPO, that is cardiac power output, because it increases both the flow as well as the pressure. So if you look at the left ventricle part, because it actively sucks the blood from your LV, it unloads your LV, it decreases your left ventricular end-diastolic pressure as well as your volume. So your filling pressures are lower, so your wall tension and your microvascular resistance are lower, and your coronary perfusion and effective O2 supply is increased. And it also reduces your mechanical work significantly, so giving proper rest to your heart. And that's where it reduces your O2 demand. So on one side, it reduces your O2 demand, and on the other side, it increases your O2 supply, and which is exactly what a failing heart requires. So the core principle of management of any patient with cardiogenic shock is feed the body and rest the heart. And this is exactly what this device does. So this is a video. I will just pause this video. I will explain a little bit of background before I play this video. So this is a patient which was treated by Dr. Sivakumar from Meenakshi Mission Hospital in Madurai. So this was 73-year-old female with last remaining vessel, multiple comorbidities and risk factor, and she was surgical turned down. So very high risk patient, and Dr. Sivakumar had decided to do her angioplasty with support of Impella 2.5 as a hemodynamic support device. And during the angioplasty, we come across a very classic hemodynamic phenomenon, which is called ventricular-arterial uncoupling. And I will try to explain this phenomenon. So when you inflate the balloon for longer duration, in particular in patient with multi-vessel disease or critical left main disease or patient with last remaining vessel. So that's the time when there is a ventricular hypoperfusion. And because of the ventricular hypoperfusion, your LV is not able to contract vigorously and generate enough pressure to overcome the afterload of your aorta. And that's the time your aortic wall doesn't open and it causes uncoupling. So your arterial pressure and your ventricular pressure, there is uncoupling because your aortic wall is no longer opening. So should this happen, this phenomenon happen in your day-to-day patient without any hemodynamic support, that's a very, very ominous sign because this patient is actually crashing. And however, when you see that when this happened with the impella support, during that particular time, your entire blood circulation to your coronaries, to your brain, to your kidneys, and your liver is dependent on impella flow during that critical time. And if you wake the patient and patient is talking to you normally. So I'm just going to play this video, and I think seeing is believing. So you can see that as the balloon is inflated in the last remaining vessel, you can see there is complete flat line. Aortic pressure, you can see there is complete flat line. So this is a time when your aortic wall is not actually opening up. And still your patient is awake and talking to you. So during this time, patient entire circulation is dependent on the impella flow. And you can see impella is giving 2.5 liters of flow. And now as the balloon is deflated, you can see the LV is again started contracting. And you can see there is a vigorous waveform of aortic pressure. So this is the beauty of the device, particularly when you do such high-risk patient with surgical turndown, multiple risk factors, last remaining vessel, low ejection fraction, this type of patient when you do, I think this device can play a significant role. In absence of this device, what many operators would prefer to do, they will just quickly get in and get out. So we can still, in some patients, you can still manage to do the angioplasty and send them home. But what happened to this patient when they go home? They have miserable quality of life because of incomplete revascularization. They will keep on coming to your hospital. There's a hospital readmissions again and again. And over the course of the time, if you follow this patient over the years, these are the patients who will be ultimately the candidate for durable LVAD or even the transplant in the long term. Now, impella increase your coronary flow velocity, and it also increase your microcirculation. So I will skip this. This is the patient on the left side actually doing a cycling in the ICU, and this patient is on impella support with axillary insertion. So early ambulation, early recovery. Ambulation is theoretically possible with ECMO, but it's very difficult to implement in real world setting. This is a video of a real patient, and she is recovering with impella 5.0 in ICU. And as she is recovering, you can see that she is lifting cables and walking down the hallway on her own with minimum supervision. So this is the hemodynamics of the device. On the left side, this is the patient criteria, typical high-risk patient that you come across every now and then in your setting. And as you inflate the balloon in this patient, you can see the mean artery pressure drops after some time, and it drops to a very critically low level. And that's the time this patient develops either cardiac arrest or slow flow or no flow type of situation in the cath lab. Whereas if you prefer to do this patient with impella support, you can see the mean arterial pressure is maintained very well, even though you do the longer balloon inflations. You can see that the pulse pressure has dropped significantly because impella is a continuous monoaxial flow device. So you will see this pulse pressure is very minimum. That is normal to see, nothing to worry when you see such type of trend. Similarly, patient with cardiogenic shock, as you turn on the impella, you can see the mean arterial pressure jumps and your filling pressure, your LVDP, goes down. So that's it from my side. I will happy to have any question from audience. Thank you for giving me an opportunity. Sure.
Does it cause bleeding competence because it's causing bleeding, especially the eye?
Yeah.
What is the approximate cost? Because I think the cost is very prohibitive. It's like some 20 lakhs.
Yes. So to your first question, because your aortic wall is very compliant unless it's heavily calcified in very few patients. But once you remove the device, there is no majority of the patient, there is no residual AI post removal of this device.
Why the device is working? Does it cause bleeding competence? Because
No, because it's actively sucking the blood and it flows inside the catheter, inside this cannula. So it doesn't cause, because it's actively unload your at very high speed of 3.5 liters per minute. So it doesn't cause, when the device is in, it doesn't cause much of regurgitation. And it's contraindicated in patients with severe aortic incompetence. So that's one of the contraindication. Yes, yes. Yes, yes, yes. Cost, yes, it's an expensive device. We understand that. But if you look at the value of the device, so but in both the setting, whether it's high risk PCI or even in cardiogenic shock, because if you use this device in early stage, like stage C or stage D of SCAI shock classification, I think these are the patients it can really, ultimately it gives you, the aim of this device is to have native heart recovery. It's not just survival, but it's a native heart recovery because these patients walk with their own heart. That's a benefit in cardiogenic shock. If the patient comes in SCAI stage E classification, then maybe VA ECMO may be the better choice, and you can use Impella as a venting strategy, because many of these patients, they are not able to come off the ECMO because it increases your afterload. It provides retrograde flow, whereas Impella provides you antegrade more physiological flow. So it can be used as a venting strategy in patient with VA ECMO as a ECPella. And once you can wean off ECMO quickly and then put the patient on Impella for a few days or couple of days, and then you can see the native heart recovery. In protected PCI, because it based on the PROTECT 2 trial comparing Impella with IBP, at 90 days there is a 29% reduction in the MACE rate. So it definitely reduces your MACE rate. And also, if you follow this patient in the long term, you will see there is an improvement in the LVF as well as NYHA class of this patient. So these are the benefit this device can provide to your patient. So improvement in the benefit in terms of mortality, MACE rate reduction, and also the quality of life. So yeah. Yes, yes. So that's nowadays in the last 3-4 years, I would say, the science has really advanced, and particularly in countries where it's reimbursed, like Germany, in United States, it's becoming very common to use both the device simultaneously, but ECMO plus Impella. So Impella, when you use ECMO, Impella always act as a less dominant device. It's used for venting on minimum flow. But the moment you start weaning off ECMO, then you have to simultaneously increase the flow of Impella, because both the device will compete for volume. So you cannot keep both devices running at very high flow. That will create suction alarm. So that's strategy. And once you come off ECMO, then you can continue with Impella, because ECMO is a great device. But you will see after a few days, you will start seeing this bleeding and then coagulopathy and all those challenges, because after all, it's extracorporeal flow device, whereas Impella is an intracorporeal device. So those complications are lesser compared to ECMO in these patients. Yeah. Yes, that's on-label use of the device, but yeah. Yes. Yes. Yeah, so if you have patient need longer duration, or if a large flow, then ideal will be Impella 5.0, because it gives you 5 liters of flow, and you can put it axillary. The benefit of axillary, you can ambulate this patient earlier, so early recovery, and gives you 5 liters of flow, and the on-label indication is 14 days. So you can keep it for longer time. And also for Impella 5.0, your motor rotation speed is lower because it's a very efficient device. So your probability of hemolysis will be lower, because it provides you 5 liters of flow, but despite that, your motor rotates at lower speed. So your chances of hemolysis are much lower with 5.0. So if you really want to use this device for longer duration, go ahead with Impella 5.0. That's the ideal device in that setting. Yeah. Yeah, that we understand. Yes. Mm-hmm. Yes.
Although I can understand there is no cost effective to the night, but at the
Yes.
same time, we're just adding the
Hmm.
20 lakh
Yes.
ultimately not able to see the patient.
Yes. That is there. Yes, yes. Thank you. Thank you. Yes, sir.
See, you said about the combined ECMO and Impella.
Yes.
And you said that you just start weaning of the ECMO.
Yes.
But on what parameters? Because Impella is supporting the heart devices, right?
Yes.
So you want to wean off the ECMO, like we usually take a help of the echocardiography. But when Impella is giving support to the heart, how can you judge the performance of the myocardial output to just wean off the ECMO? Because Impella is already giving a support to it, and you want to remove the ECMO actually.
Yes, so I think because ECMO is used particularly in stage E of sky shock classification, the ECMO is a very powerful pump, right? It can give you up to 7 liters of flow. But the big disadvantage of ECMO, it feeds the body, but it doesn't give raise to your heart. So it increases your afterload substantially. And many patients may go into situation where sometimes their aortic wall is not opening because of high afterload. And that's time you see that aortic wall thrombus, and these patients are very high risk. And after a few days, maybe 2 or 3 days, if the ECMO has supported the initial, it reduce your lactate down. But if you're not able to wean off this patient, ultimately these patients actually go. So to your question, ideally for every hemodynamic device, your PS Swan guns is a mandatory. We are almost make it mandatory to use Swan gun because it provides you multiple data points to make certain decisions, whether it's a weaning or escalation at the right time. It provides you your wedge pressure you can calculate. It can CVP to wedge ratio to see how the right side and left side is doing. And I think that gives you significant. You can also calculate your PA saturation, based on which we can calculate cardiac output. And once you have cardiac output, we can calculate cardiac power output. So all these things you can only do with PA catheters. And that's the reason when you use hemodynamic support devices, whether it's ECMO or Impella, PA catheter or Swan guns is very, very important. That can guide you the treatment. And weaning, again, you have to follow simultaneously to 2D echo to see the point of mixing, because ECMO is providing you retrograde flow and Impella is providing anterograde. So you have to ensure that point of mixing of the blood is not at the when your arteries in the brain takes off, right? So you have to, it has to be distal to that. Otherwise, you will see that north-south syndrome or Harlequin syndrome. So those things you have to be very careful when you do both the devices simultaneously.
But the modalities to wean off the ECMO, the echo parameters, like the protocol of echo parameters, will not work effectively, right? When the Impella flow is increasing.
Yes. So I think you have to look at multiple parameters, like your systolic, diastolic, mean arterial pressure, your lactates. If your lactates are lower, then it means your perfusion has improved. Now it's a good time. Maybe you can also do 2D echo to check the native heart contractility, and you can also do the weaning trial. So on ECMO, so that those gives you some information.
Metabolic parameters are more important.
Yes. Yes. Lactate particularly is very important. Yes.
Thank you.
Yeah. We have used over 100 devices in last 3 years, and majority of the indication that we have used is for protected PCR, high risk PCR in elective patient. There are few cases, of course, we have done with cardiogenic shock also. Even the surgical setting we have used, like as a bridge to transplant. The first cardiogenic shock patient we use in India is a bridge to transplant patient, and where Impella CP was there for 2 weeks time. So we have good success rate in India. Cardiogenic shock, actually, when we want to launch, we had to have certain training, certification, and commitment from the hospital, because this is the device where entire team, including your ICU team, your surgeons, your interventional cardiologists, all of them needs to be properly trained, because ICU team is the one who's managed this patient post-implantation. So training is very important that we emphasize to launch a shock program. But for elective PCR, I think you can give us prior 2-3 days advance notice, and we'll.
What is the average cost?
So cost is, we can discuss it, but it's around 20 lakhs rupees. Yeah. Okay, thank you very much for the wonderful questions. Thank you.
Thank you, Dr. Kamlesh.
Thank you, Dr. Kamlesh. Now we will start with Dr. Guil Hermes' presentation on innovation in Bentella's procedure, autosave transcatheter endobellital device.
Thank you. Can you see my screen?
Not yet, sir. Yeah, now we can see it. You can
okay, thank you. Thank you for the invitation. I will present you this new innovative device for the percutaneous endobental surgery. We are a PNF company, and we are committed with this idea of keep the intervention safe and simple. And this, what we are doing with this new portfolio of device. We have a very complete portfolio for the valves for the structural heart disease, with all the valves, including also some stent grafts. And with this portfolio, we saw that it's possible to move forward in the direction to have a combination of the technologies. Then the AortoSave, this is the name of our device for the bento de bonus surgery approach, percutaneous approach. It's a combination of technology, and we include some remarks making this device ready to use using our dry tissue technology to have an off-the-shelf device ready to use by implantation to totally percutaneous for the aortic, ascending aortic, and valve replacement. The idea of this device, it's a combination of the main three technology, the transcatheter biologic aortic valve, plus the technology of multi-branched aortic stent grafts, plus the coronary stent grafts, the PTFE covered grafts for coronary arteries. Then if we saw this, we have all the technology for these parts, and now we are putting all together in this new device. The device mainly, it's an aortic valve with extending graft to the ascending aorta. It's like a modular device. We have the valve with the standard size of the valve from 23 until 31 millimeter, 23, 26, 29, and 31, ranging annulus from 20 to 29. And then we can extend this to the ascending aorta in a patient-specific design or some off-the-shelf sizes. And complementary to this, we have internal branches in the device to connect the coronary grafts that will be a bridge connecting the device to the coronary arteries. We can use in this connection self-expandable stents or balloon expandable stents, both covered by PTFE. Then all of this will make our device the AortoSave device. This is the idea of the implantation, and to make it simple and possible and reduce the time of intervention, we have a device that allow us to do a pre-catheterization of the internal branch of the device of the AortoSave, the implantable device. Then we will save time to do this cannulation of the device. And we also can use this to connect the coronary arteries. Then we have these steps for the deployment. We will put the device in the position in the aortic valve. We will rotate and find the right direction of the coronary branch. We will partially open the device. We will expose the coronary guide wires. We will pre-connect the coronary arteries. Then we can move to deploy the device and connect with the grafts. For this, we use this delivery device. The delivery device, we have a very large range of the sizing from 22 to 28 French, according to the specification of the implantable part that we will use. Then as we have this option of patient-specific design, we have different sizes for the delivery device. To make possible to have this pre-cannulated, we used our proprietary technology for the dry tissue. We use bovine pericardium, and we keep this preloaded in the device. Then we can do the loading and pre-cannulation of the parts in company. Then it's ready to use when you receive this in the cath lab. This treatment of the pericardium, we can increase the mechanical resistance of material as we can preserve this in a wet way. And we show here that we increase the mechanical properties of the material, and we will have the same, after hydratation, we will have the same properties as the standard pericardium. We also increase the thermal resistance of this material. It's more stable than the conventional pericardium that we use in the heart valves. And we preserve all the collagen and biological structure of the material. Then it's safe to use this material. And for this valve application, we also, using this pericardium, we apply an anti-calcification treatment to increase the lifetime of this material after implanted and increase the biocompatibility of the material, trying to avoid the degenerative issue with the prosthetic valve. We have all the characterization of this material with long-term testing for this. And this is how you will receive the material. It's ready to use, just flushing to prepare the valve, and it's ready for usage. And for this material, it's a new treatment for bovine pericardium, but we are already using this in our device-in market. We have more than 3 years experience with this dry tissue pericardium, and we are using the same for our aortosafe device. For this aortic intervention, it's a complex intervention. We know that it's a very complex procedure. Then we need to be very cautious and intensive in the measurements. We start using the same measurement of the TAVI procedure, with all the measurement in the aortic root and the tubular portion, the sign tubular junction. Then we extend this measurement to the whole aorta, like we plan branched TIVAR device. Then we need to extend this measurement to the aorta, and we use the same protocol to ascending aorta as we do for TAVI. We need to find the angulation of the coronary arteries, the length that we have, the sizes and the diameter to find the right valve, and then to see the angulation of the coronary arteries. We need to check carefully the size of the coronary artery to be compatible with the size of the branch inside the graft. Our indication here is to use the same size of the branch as the coronary artery. Then we will have the same oversizing for the stent, the bridge stent in the graft and inside the coronary artery. And this is how we have this device. It's a night null frame, a self-expandable night null frame covered by a polyester graft. We have, for the valve, we have an outer skirt to avoid any issue with paravalvular leakage. As we will have no access for the outside of this device, then we need to avoid this paravalvular leakage. It's one of the risks that we have for this device implantation. And we have this bridge, this connection with the internal branch. We have some specific radiopark marking because we need to orientate this device and do this. We are do this orientation. We are moving for some off-the-shelf device based on literacy review of the sizing and positioning of the coronary arteries. Then we are using all of this anatomical information to have some ready-to-use size. And we are basing our positioning on these new technologies and new techniques used for TAVI deployment. This is one of the main orientation that we have for the off-the-shelf device. It's the alignment of the commissure. Then we will use this orientation, the basic orientation, to orientate the branch of the device. Then the implantation will be guided like we use for the cusp alignment, commissural alignment in the TAVI procedure. Then we will keep the leaflets in the same position as the native leaflets, and with the orientation of the hole, the exit of the internal branch close to the same orientation of the patient. And for some cases, we know that we will need to have patient-specific design. Off-the-shelf design will not fit for all the patients. Then we will need to work with the specific patient design. And in this case, we move like we do for grafts, for multi-branched grafts, with the measurement, with the reconstruction of the anatomy of the patient, checking all the parameters and tailoring this device for the patient using the same size of the valves that we have, the same size for TAVI with the patient, a specific patient designed for the graft. And then we will put all of this together. It's the concept of our delivery device. Then we have a device for self-expandable devices with controlled deployment of the device, but we add in this case some channels for the connection with the coronary grafts, internal branches of the graft, the prosthesis. Then we will keep a guide wire inside, a guiding catheter inside the internal branch. Then when we deploy the device, we will already have the guide wire. Then we will save time in this intervention and reduce the risk of lost disconnection. This is some details of how we will have this connection. We have valves, we have access ranging from 4 French to 7 French or 9 French, according with the design of the prosthesis that we are using and the sizing that we will have for the delivery device. As I present before, we can have a range from 22, from 28 French. Then we can change the access, the kind of pre-cannulation, and we will have size for the delivery device. This is a short video showing how we do this planning and we test our device in the lab. Then we can see the partial deployment of the valve. Then we expose the branch. We have the guide wires that we can move. We can connect the coronary arteries. Then we will fully deploy the valve and we will keep this access inside the coronary arteries. Then we can move to cannulation with the bridge stents, the PTFE covered stents. In this case, we are using subclavian access. We are starting our clinical use with the axillary or subclavian access, because we know that it's important to be very precise on the rotation of the device. Then we are making shorter and avoiding the crossing the arch to keep this precision for the deployment. This is a summary of the device. It's a bovine pericardium dry tissue valve in a self-expandable nitinol frame. This nitinol frame, it's the same for the valve and the graft. It's all nitinol. We have a polymeric skirt to avoid the paravalvular leakage. We have the internal coronary branch, and we have the valve preloaded and pre-cannulated inside the delivery device. That allow us to do a partial and controlled deployment. And we have some off the shelf and patient, and we can do the patient specific design. We see this as a new promising approach to this so complex intervention. And we combine the TAVR plus the multi-branched stent graft technology. We need for this planning and procedure a very intensive study and planning of the case. And with this dry tissue technology, we can move for complex device without the limitation of the loading in the cath lab. Thank you.
Thank you, sir. Any questions? So we'll move to next topic by Dr. Gin Tatos about Prorecto with FlexNav TAVI system enhancing innovative technology to optimize patient outcome after TAVI.
Okay, let me see. Let me try to share my screen. I hope my screen is visible.
Not visible yet, sir.
Not visible yet.
Ah, yeah, now you're visible.
I'm visible. Okay. Yeah. All right. Okay, so the topic is portico transcatheter heart valve with a FlexNav system. My name is Gintautas Bielauskas. I'm working in Copenhagen University Hospital, Rigshospitalet in Denmark. I have a conflict of interest, which you can see on the screen. And I would also like to make an acknowledgement to my dear colleague, Lars Sandergaard, who's professor, my colleague in the same department, who contributed a lot to this presentation. So for those who are not familiar with portico valve or who have not seen it before, first a short introduction. It's a self-expanding stent with large stent cell design. It's fully repositionable and retrievable system. It's, by the way, was the first system on the market to be fully repositionable and retrievable when it was launched back in 2014 or 15. It has bovine pericardium leaflets, intra-annular leaflet position, so low-sitting leaflets, intra-annular position, porcine pericardium sealing cuff internally, anti-calcification treatment on those leaflets to promote durability. And it currently has 4 valve sizes ranging to cover the annuals from 19 to 27. So it's a 23, 25, 27, and 29 millimeter valve. What's new quite recently, it's a new delivery system called FlexNav, which allows for sheathless approach while performing a transcatheter aortic valve implantation. It's nicely hydrophilically coated. It has a stability layer on it, which makes the whole deployment of the valve more predictable and stable. We'll take a look at that in the subsequent presentation here. Now, in order to kind of summarize the most important features, you will see them highlighted and numbered. So we'll go through 9 important aspects of this valve and this delivery system. So first of all, what is important for the cath lab staff, it's actually a very fast and easy valve to load. It does not require a cold saline. It requires short rinsing in a couple of bowls, and then it of course contains the valve, loading and delivery system, and an experienced loader can usually do the whole process of loading in a matter of a couple of minutes, 2 to 5 minutes, usually what it's required to load the valve. And that's appreciated by a cath lab staff who's loading. In our case, these are cath lab nurses, and they like this system very much. Now, second introduction. This valve has one of the smallest introduction profiles on the market, and that is important, as we have recently seen in a meta-analysis of quite a few 8 randomized control trials comparing TAVI and surgery. The benefit in mortality for TAVI patients was primarily driven or seen in the subgroup of patients who were treated transfemorally. and not seen in those who were treated transthoracic. And obviously, a transfemoral approach is seen as a preferred approach for better outcomes. However, if that's pushed too much, if transfemoral approach is used in anatomies that are not very suitable for it, it may also end up in dramatic complications, even fatal complications, as shown in this particular case. And then the new FlexNav delivery sheath with integrated inline integrated sheath on it, it comes handy. It is equivalent to 14 or 15 French introducer, and as compared to the other devices out there on the market, it has actually the smallest or profile to introduce, and a smallest footprint, you know, because some of those devices, as balloon expandable devices, they have small expandable sheets, for example, but then the footprint they create at the time of passing the device through the sheath is actually larger. So Portico with a FlexNav, it's one of the smallest profile. It's nicely hydrophilically coated, and it tracks very easily, which takes us to the next step: flexible delivery system. It's indeed, it's been tested by the R&D department and compared, let's say in this particular example here, with delivery system from Evolute valve, and in many parameters where R&D measure the force required to push the device, the forces required to deflect the catheter, the friction forces, it's in almost every aspect, it's quite substantially easier to push this FlexNav catheter through the difficult anatomy. And let me give you an example. This is one of the patients we actually treated in our own institution with quite acutely angulated aortic arch, which we missed at that time on a pre-screening CT scan. And when initially trying to go through this arch with one of the stiffer valves we had at that time, the patient complained of a sharp pain in the back. This was done in the local anesthesia, this procedure, as almost all procedures we do. And of course, when doing contrast injection, we could see the perforation in the arch. So we are the same team who also do TVAR in our institution. So we moved forward and quickly did some measurements of this aortic arch and performed TVAR. And then we switched to another more flexible device. And in this case, it's Portico valve. And you can see how easily it tracks through this quite difficult and in this scenario, even stented aortic arch, and goes down to the aortic valve. And we finish up the procedure with good result. The day was saved. It was still performed under local anesthesia, and the patient was discharged uneventfully a few days after. Flexibility of the delivery system and the capsule there is actually ideal also for difficult anatomy such as horizontal aorta. And as you may know, some stiffer devices, they do not listen to the wire. If you push that wire towards the ventricle, they may still, the capsule may remain quite vertical at the level of ascending aorta. And you can try to put it really high in the relation of non-coronary cusp, but then typically you have to accept whatever comes up at the level of the left coronary cusp. At the same time, with Portico, the capsule is much more flexible, and usually the way we do it, the first operator is using the left hand to adjust the depth and the right hand to unsheath, to rotate the wheel and release and unsheath the valve. At the same time, the second operator has a good grip on the handle and can push or pull the wire in order to make it more coaxial with the annulus plane. And by using this technique and by choosing the more flexible Portico valve in these difficult cases, we can, even in difficult anatomies as shown here, we can typically achieve a good result. Now, paravalvular leak, we all know it's an important part when doing TAVIs, and anything more than mild in terms of paravalvular leak is associated with adverse outcomes. Now, Portico valve has a stent design which consists of large cells. And those large cells, they have a good chance of adapting towards nodules of calcium. In early days, paravalvular leak was also sometimes caused by by choosing a wrong device. It was done ultrasound based. Now these days, we typically choose a device which fits well in terms of sizing. However, the calcium chunks, they may adapt better or worse. And in case you have a stent frame with small cells, those chunks of calcium, they may push the frame a bit away. They may adapt less favorably as compared to the portico valve, which has a large stent cell design, and typically that allows nice apposition to the wall. Now, conduction abnormalities, another thing where portico valve, has a favorable design and favorable results. It has a short protrusion into the left ventricular outflow tract, and very importantly, it has such a conical design which is not flared. It's not flaring. It has a cylindrical design which is not flaring into the left ventricular outflow tract, and that exerts, to our best understanding, less forces onto the conduction system, minimizing the risk of conduction abnormalities. Also, again, as being the first valve on the market which is fully repositionable and resheathable, you can typically aim for optimal placement of this valve. Usually we start, being ambitious, pretty high on the higher end, and then in terms of aortic annulus, and then in case the position is not optimal, it's easily possible to resheath the valve, reposition until you obtain the desired depth. The IFU suggests 3 to 5 millimeters below the annulus as the optimal depth. We usually aim for approximately 3 millimeters below the annulus here in Copenhagen. Now, while placing the device, another important feature is the patient remains usually very hemodynamically stable as we unsheath or resheath, as the valve has intra-annular leaflet position. Those leaflets, they start functioning very early. As soon as the valve makes touchdown, makes contact with the LVOT, the leaflets are basically functioning. And that is nice in a couple of ways. One, then hemodynamic instability and blood pressure fall at the time of valve release is much less. And also, in many cases, it does not require rapid pacing for the heart. And that's really nice when you have a patient who is at risk, such as patients with low left ventricular ejection fraction or severe mitral issues, such as moderate regurgitation or pulmonary hypertension. All these patients, they benefit really well from this technology here. Access to the coronary arteries, yet another thing which is getting more and more attention in the medical community. So, as you know, we may classify transcatheter aortic valves based on the frame height and leaflet position. We have low frame devices, which obviously have intra-annular leaflets, as shown on the left. Then we have taller frame devices, still with intra-annular leaflets, as portico valve has. And obviously, accessing coronaries with this design is a bit easier as compared to tall frame devices with supra-annular leaflets, where leaflets are sitting higher up and may end up in more technical challenges to access the coronaries. This was shown in a recent reaccess study which was published, and there were 300 patients were included, and coronary cannulation was attempted before and after TAVI, and it was unsuccessful in 23 patients here. And however, out of those 23 patients, 22, if I'm not mistaken, were treated with Evolut platform, and only a very small amount, one patient or so, was treated with another platform, illustrating the importance of that. Not only the importance of the leaflet height, but also the importance of stent cells As said before, Portico valve has large cell design, and that allows crossing of those cells easier. What is also important when we talk about coronary access after TAVI is commissural alignment. When we position TAVI valves, if we don't pay attention to the commissural alignment, then those valves land randomly, where some patients will have a good commissural alignment, where transcatheter aortic valve commissures are aligned in the same way as the commissures of the native valve, and obviously then accessing the coronary is easier. However, in some cases, commissural alignment will be not favorable, where commissural posts will be sitting in front of the ostia of the coronary arteries. And in case of this situation, accessing the coronary arteries may be really difficult or impossible, as shown in the previous study. And Portico valve is actually can be aligned and with the native commissures. We have recently published a paper on that, where we compared 3 designs. We compared Portico Accurate and Evolute in terms of how they perform in commissural alignment, and Portico valve can be aligned. To make that happen, what we take advantage of cusp overlap view. So where we, and as you may know, medical community, at least in Europe, is transitioning to deployment of TAVI valves in left-right cusp overlap projection. In that projection, which is usually areocaudal, we're overlapping the left and right coronary cusps on the right side of the screen and exposing the non-coronary cusp on the left side of the screen. And in this particular view, if we can also position one of the commissural posts to the right of the screen, we can usually obtain commissural alignment. And Portico valve has identifiable markers. Those commissural posts can be identified on the fluoroscopy image. This is how it looks like, closer to the live view in the cath lab. So again, a cartoon here, which shows isolated non-coronary cusp on the left of the screen and overlapping other 2 cusps on the right of the screen. And we know that there is a commissure in between these 2 overlapping cusps. And then if we can try to, if we identify the commissural posts of the Portico valve, and if we can rotate it so that it's facing the right side of the screen, we can end up having a nice commissural alignment after valve release when we work in this left-right cusp overlap view. And that's what we routinely do in our cath lab. Why is it also important in current era? Well, up until now, we were treating mostly elderly patients, at least here in Europe. The typical patient would be 80 years of age or so, who is getting TAVI. And then typically the TAVI valve, it outlives the patient. And TAVI is not, or has not been an issue up until now. However, there is more and more talk, and it's reflected in the recent guidelines and recent studies, that TAVI technology is expanding towards younger people, younger patients. And it may be that in the future, we will consider using TAVI valves in patients who are 60 years of age, for example, and qualify for biological aortic valve implant. And then if we assume that TAVI durability, let's say, is 10 years, we don't know that, this is an assumption, that may lead to TAVI in TAVI procedures a few times in the future, should the patient live until he's 85 years of age or something. And what happens then, of course, if we come back to our drawing of intraannular or supraannular leaflets. So in case of the intraannular leaflet design, the TAVI in TAVI procedure may not be a big issue. However, if we have supraannular leaflets and we do TAVI in TAVI, we do create a long tunnel of tissue, which may cause access to those coronary arteries, may make it really problematic in the future. And this is a topic which is now receiving a lot of attention and thought. And again, Portico valve in this context also has quite favorable design and may benefit in the future. Now, hemodynamic performance of the valve is, of course, yet another very important feature. And as we all know, patient prosthesis mismatch is something to be avoided. And the recent study from Portico IDE trial in US, it has demonstrated that actually Portico valve self-expanding intraannular technology compares very favorably with Evolute valve, which is self-expanding supraannular technology, of which we often think as like a gold standard in terms of opening area. But yet again, in this study, we can see there's virtually no or very minimal difference between the two, which is good to know, and which suggests that by using portico valve, we can actually avoid patient prosthesis mismatch as much as possible. Now, in summary, portico valve offers remarkable deliverability with the integrated flex nav system, delivery system, which is nicely hydrophilically coated and very flexible. It requires much less force to be pushed through difficult anatomy, should it be tortuous iliac arteries or a difficult arch or horizontal ascending aorta. The valve offers excellent hemodynamics, which compares perfectly also with self-expanding supraannular valves. It has excellent clinical outcomes, no worse than any other player on the market. It has good profile in terms of future coronary access, and this constitutes, you know, the features of a good TAVI valve as we see it from today's perspective. A glimpse to the future. This is not, as far as I know, yet available in India, but this is approved in Europe. That's a next generation valve, which is called Navitor, and there are some optimizations on it, including optimized radial force and optimized features to avoid paravalvular leak, including the active outer cuff, and even increasing annulus range. At the moment, it's CE mark approved for the annuli between 19 and 27, and ongoing studies are for the annuli 27 to 30. So I'm only showing this as a glimpse to the future so that you know what's upcoming. And still, this design remains very similar in terms of other good things, such as big cells and early function of the valve, no need for rapid pacing, of course, fully recapturable, repositionable, retrievable, and very importantly, no sacrifice on delivery system profile, which is still equivalent to 14 or 15 French sheath as it is today with portico valve. Finally, one example of the recent case performed in India where portico valve was used with a flex nav system in very calcified anatomy. Initially, you can see the valve was a little bit constrained, but after the post dilatation, it's really a perfect result with excellent valve implant height, no paravalvular leak, and good valve function. So that was it from me. I would be open to any questions. If
thank you, Dr. Gildas. I think there are no questions. Thank you.
All right. Have a nice day.
You too. So we will start with the last presentation of the day. It will be by Dr. Ajit Bana. The topic is sutureless aortic valve replacement, a trend or a limo concept.
Good afternoon, everyone. I would like to thank organizers of this exciting Heart Summit for giving me an opportunity to share my experience with sutureless aortic valve. I'm sorry I'm not in Ahmedabad with you all due to some personal reasons, and I am presenting my experience or my views on sutureless valve through this video. So sutureless valve is not a new concept. It was developed by Crony in 1960s, but somehow it did not work well. But now there are three types of valves. Out of these, Medtronic 3F enable is not in market, where the Edward entity is basically you need three sutures. The pure sutureless valve is only Sorin perceval sutureless. Sorin perceval sutureless valve is a different type of technology in which there is a stent and there is a valve, pericardial valve mounted onto this stent. So it has an outflowing, it has a sinusoidal struts, and it has an inflowing. The valve, which is made of is bovine pericardium with a double sheet design, and the stent is a nitinol stent. What is the beauty of this nitinol stent? When it comes into the temperature or body temperature of the patient, it expands. And it has a carbo film coating onto it, so there is no clot formation. So in this particular valve, we collapse the valve in such a way that it becomes very small, only 14 millimeters. So it facilitates our minimal invasive procedures. And because in this valve, we are not crimping the leaflet, whereas in transcatheter valve, we all surgeons think that there is a crimping of the leaflet, so pericardium can be damaged. Whereas in this particular valve, there is no crimping, there is only collapsing. So leaflets are intact, there is no damage. We have a precise positioning by 3 guiding sutures, and we have an eyelid onto this particular valve. So it is very easily reproducible by any surgeon after 1 or 2 valve. So it can be used in aortic stenosis in adult patient and sometimes in aortic stenosis and regurgitation also. What are the features? The patient should have a sinotubular junction to annulus ratio of less than 1.3. If it is more than 1.3, it means the ascending aorta is dilated and this valve is not suitable. For example, where it is contraindicated, like the aneurysmal dilatation of ascending aorta or dissection, congenital bicuspid aortic valve, known hypersensitivity of nitinol alloy, or as I told you, when the ratio of sinotubular junction to annulus is more than 1.3. In some of the type 0 bicuspid aortic valve, definitely it cannot be used, but in some type 2 bicuspid aortic valve, we can use sutureless perceval valve, but not in initial practice of ours after gaining some experience. This valve gives fantastic gradients because there is no suture, so you are not crimping the annulus. And by any of the sutured valve, the gradients are far, far less. And proven a long-term the efficacy of this valve by the various study. Initially, it was a 5-year. Now, 11-year data is published with a 98% structural valve freedom. The first perceval valve was implanted successfully in 2007 by Dr. Bart Marquis, and after that he published his experience when all the patients were more than 75 with intermediate risk and fantastic results. Later on, the 700 patients, a multicentric trial was done onto this valve, which is known as the Cavalier trial. And Cavalier trial has various characteristics. Majority of patients are more than 70. Euro score was high. And you can see the procedure success was 95%. Cross-clamp time and CPP time was significantly low, even if we are doing a minimal invasive procedures. And morbidity mortality was in acceptable range. And the observation of this trial was that operative time and CPP time can be reduced by using a sutureless valve. Hospital stay also reduced. Convenience in using an MICS patient, this gave a very low gradient and satisfactory 30-day mortality. After that, a long-term data of 400 patients with 11-year data was published, and it shows that the patient, even for the intermediate and high-risk Euro scores, have concluded with a combined procedures, mitral replacement, aortic replacement, CABG, etc. And they found out that their mortality was very low, the morbidity was acceptable, and their observation told us that the early stroke and mortality at both 30 days and 2 years were better than reported in both the conventional surgical and transcatheter valve in larger trials, comparing the Sauer and Tower in combined cohort patients. Perceval sutureless valve offer a stable, time-saving and safe surgical results both in isolated and combined procedure. Lower incidence of structural valve dysfunction has been noted up to 11 years. And the trial of more than 700 patients gave a, especially these particular patients were again more than 70 years of age with a high Euro scores, survival and freedom from reoperation was significantly good, and patient has very low morbidity and mortality. So now we wanted to find out whether this valve have some benefit in the high-risk patient. That's why the SIR registry were done, which were comparing all the risk, low risk, intermediate risk, high risk, and very high risk. Even patient having a risk of more than 20% shows exceptionally good results, very easy use in minimal invasive, CPP time and cross-clamp time was low, and operative mortality even in very high-risk patients was 2.7%. So it was ICU stay and hospital stay was very low, even in high-risk group of patients. So the observation of this study told us that the suture valveless rapid deployment valve is effective and ensure excellent results. High incidence of MICS, especially beneficial for high-risk patients. SIR registry favored outcome, especially in high-risk patients, usually who are the candidate of TAVI. So if we have a candidate for TAVI who has no money for TAVI, we can give a minimal invasive approach and put a sutureless valve, patient will be benefited the similar way. Persist AVR trial is comparing the suture valve, available suture valve with the sutureless valve. And this, two arms of the suture valve and sutureless valve are matched properly, and they have then segregated them in all the parameters. And after that, they found out that the 20% to 18% less CPV and cross-clamp time in compared to the suture valve when we use the sutureless valve. The endocarditis and other thing was similar with suture valve, sutureless valve. And the primary endpoint means the freedom from maze was exactly same in the suture and sutureless valve. It means if you're using a sutureless valve, you can give excellent hemodynamics, your operative time is less, and you have the similar results as the sutureless valve, except one thing. The sutureless valve, initial experience have shown that there are high incidence of pacemaker implantation. But as the two surgeons in the below have shown that their experience, as their experience advanced, their pacemaker number went down. So if initial patients may have a high incidence of pacemaker, but as your surgeon experience increases, the pacemaker implantation rates go down. As similarly, the patient class, NVHA class, etc., hemovalve dynamics, etc., was absolutely maintained up to 1 year. So observation is Perceval is equivalent to the stented valve. It is facilitate the combined procedure. It is comparable to any bioprosthetic valve. Perceval provides optimal sealing at the annulus. There is very low PVL. Higher incidence of PPI is noted, but next generation valve, which is Perceval Plus, I am sure this design will further reduce the pacemaker implantation. But in my experience, I have zero pacemaker implantation. Sutureless valve is a reliable and essential technology within the modern therapeutic armamentarium to treat aortic valve disease. So who are the benefit patients who can benefit it? Patients who are sensitive to cross-clamp time means a high-risk patient. To a patient who have a challenging procedure like the redo, calcified aortic root, or patient who need a minimal invasive like the obese patient, or the patient do not want to square. All these patients can be benefited by this particular valve. The cross-clamp is very sensitive patient, high-risk patient who are sensitive to cross-clamp, they can have a high mortality, especially if the ejection fraction is low. And if you use this particular valve, this trial has shown by using a Perceval sutureless valve, the mortality in this, even in elderly patient and high-risk patient, was significantly low. Wound complications were low. And even in reoperation settings, less bleeding and fewer transfusions were required after the use of Perceval sutureless valve. Obese patient, when we are using MICS procedures, less morbidity, less mortality, shorter hospital stay by use of sutureless valve. And patients who have calcified aortic root, it's a surgeon's nightmare. It's very difficult to take the suture onto the annulus. So just take 3 guiding sutures, set your valve properly, and just deploy this valve. You will come out without any complication. And calcified aortic root, this data, this particular paper has shown has a significant advantage by using the Perceval sutureless valve. Small annuli, which is a challenge to all the surgeons. We always worried of PPM. This is the valve. Even in 19 size or 18 size annulus, you put a 19 or small size valve, which gives a single digit grade, or maybe 10, 11 mean gradient. Patients who are at risk of PPM means a small aortic annulus. This is the valve. If you use this valve, the PPM is low. You can see by this paper that the Perceval sutureless valve used can reduce the PPM even in a small aortic annulus. Sometimes surgeons say that I can enlarge the root. There is no problem. Yes, you can enlarge the root. But if the patient is frail female, is a high-risk female, why do you enlarge the root? Just put a Perceval sutureless valve. It has a comparable result. This paper has clearly shown us. So let's compare the surgical sutureless aortic valve with TAVI. Stroke or similar. PPI is more in TAVI. Pesco complication is more in TAVI. PVL is more in TAVI. Gradient is less in TAVI. And the morbidity and mortality was similar, even in high-risk patients. The Perceval sutureless valve can be used in failed hemograft, bicuspid aortic valve, triple valve surgery, and aortic insufficiency. But I will advise you not to jump onto this. First, have experience onto the elective routine patients, and then we can think of experimenting on other things. So ESCC, till now, we have implanted in 32 patients, majority of male, mean age was 67, majority of patients were low to intermediate risk, and 30 patients have a normal sinus, where the 2 patients have right bundle branch block. despite right bundle blanco. Severe aortic stenosis was the predominant, where some patient have aortic stenosis regurgitation. LV ejection fraction less than 35% was noted in 4 patients, and small annulus less than 90 mm was noted in 3 patients. So isolated aortic valve was 22 patients, where the mini upper sternotomy in 7 and right antithoracotomy 9 patients, where the some patients we need to do a mid sternotomy with various regions. Combined procedures with CABG was in 10 patients. Cross-clamp time and CPP time, you can see even in combined patient it has not increased. Failure to implant was in 1 patient, and that was my wrong judgment. That patient was having particularly bicuspid aortic valve. It was type 0 bicuspid aortic valve. That's why the valve was either diving inside the LV or coming out. So I removed this valve and then placed a sutured valve. You can see intraoperatively, majority of our patients is medium to large, means 23 to 25 size valve. XL means 25 to 27. 5 of our patients received 25 to 27 size of aortic valve, which is very, very rare in Indian setting. And new onset atrial fibrillation was noted in 3. Few patients have developed complete heart block, which recovered after some time. And 1 patient had, but 3 patients have persistent LVB, and we are following them up. P gradient, you can see, mean gradient, you can see the significantly reduced in this particular patient, and few patients have shown a improvement in ejection fraction after follow-up. And we are following them up very properly and keeping all the data, and we have seen that the gradients are maintained up to 1 year in all the patients who have completed first year. So, in my conclusion, rapid deployment, sutureless valve, especially perceval, reduce the cross-clamp time and CPP time, which is important in high-risk group of patients. Solution for a small and calcified aortic root, alternative to root enlargement, and especially in high-risk patient, facilitate minimal invasive aortic valve replacement. Procedure produce low gradient, especially in reduction of LV mass, and provide a satisfactory long-term durability. So think of a situation. What is give sutureless valve and minimally invasive AVR? If we combine these two, what it will give you? A direct visualization, annular deployment, shorter press-clamp time, and faster atraumatic implantation. It means by using a sutureless valve and MI-AVR, we are addressing the limitation of both surgical valve as well as transcatheter aortic valve. So the sutureless valve is not a limbo concept, but it's a great idea in an innovation dry cardiac surgery field. So we surgeons should also innovate and start using perceval sutureless valve whenever it is required. Thank you very much.
Thank you.
Dr. Ajit, Rajneesh, I just want to ask you one question. Can you hear me?
Sir, he's not live. It was a video, sir.
Sorry.
So I will.
I can hear you. I can hear you.
Zoom call.
Yeah, I can hear you.
Yeah, so just one question I want to ask you. I mean, I've also been using the sutureless valve. The only thing I just want to ask you, because since you at your center in Jaipur are using both, I mean, transcatheter valves as well as the sutureless valves. So if the finance is not the constraint and patient is 75 years, what would be your choice? A sutureless or a transcatheter? Patient has just left it to you. It's not, I mean, giving you any preferences. Cost is not the criteria. Then
perfect question. I think I will evaluate the patient. 75-year-old person can be a high risk for TAVR and maybe a low risk for surgical aortic valve replacement, because sometimes a difficult anatomy of aortic valve means calcification of LVOT, which surgeon can remove it very good, nicely, and in TAVI patient can develop problems. So if 75-year-old man is not a high risk for TAVI, I'll go for TAVI, and otherwise, if the anatomy is not suitable for TAVI, then I will go for surgical aortic valve replacement and preferably put sutureless valve.
I will endorse the same. I think a sutureless valve, I mean, it's a really good. I think all the surgeons, I mean, they should learn it. It is one of the easiest, I mean, valves to deploy, and it can be really a boon in the small aortic root, which can really help us in our patients. Really, it was great listening to your talk.
Thank you. Dr. Rajneesh taught me to implant this valve.
I have one just curiosity. What about redo actually? If some patients is having a perceval and if they need redo surgery, aortic surgery means.
I think it is the same as for as it very good quality of this valve with nitinol is that you put a cold saline into it. If you put a cold saline into it, it will become very flexible.
Even after, for example, even after 5 years, once it,
then there will be a little challenge because it will be endothelized, but it will come out. I believe it will come out easy with a little dissection because nitinol is the only metal which can be collapsed very easily after making it cold.
Okay. Thank you, sir.
Thank you very much. Thank you.
Thank you, sir. I would like to call Dr. Gaurav Goyal for the closing remarks.
Well, saving the best or the worst for the last, and thank you all for joining us at Ahmedabad at the first ever hybrid heart summit, wherein we were able to bring all the three arms of cardiac care, the surgeons, the cardiologists, as well as the anesthetists on a common platform. And I hope that the tradition will continue at least biannually. Couldn't have been possible without the audience who've come up with wonderful participation and questions and answer sessions. The industry without whose support it wouldn't have been possible. The key organizing committee members, Dhaval, Dr. Naman Shastri, Dr. Samir Dani, and 360 people who have really put in their hard work and labor to make it all happen, and Hotel Hilton for their hospitality and providing all the logistic support. Thanks a lot once again, and it's been an honor to serve you, and we'll have more such events very soon. Thanks a lot.